Yes, sir.
All right. Good evening. I'm Dr. Parag Biniwale, Chairperson-elect of the Indian College of OBGYN, and it's indeed a pleasure to welcome all of you on the third day of certification online course on aesthetic, functional, and regenerative gynecology. At the outset, let me appreciate the efforts put in by our conveners, Dr. Ragini Agarwal and Dr. Narendra Malhotra, and our coordinators, Dr. Suman Sinha and Dr. Apurva Kumar Datta. Last 2 days, we've had very good attendance and excellent deliberations. I'm sure all the delegates have appeared for the post test because it is imperative for you to appear for the post test and secure at least 50% marks each day on all 3 days in order to have a certificate from the ICOG. So today is the third day, and we are going to have some interesting sessions on the vaginal non-surgical management of SUI, scar and stretch marks, anti-aging, and then finally one very interesting panel discussion will follow. So without much ado, I hand over to Dr. Ragini Agarwal, who's the convener of this program, to take it ahead. Thank you.
Thank you so much, Parag. Very welcome to all of you. Today's last day of the 3 days ICOG certificate program. And we are so happy that everybody is really joined in quite a big number and interested in this program to understand what it is and how it is different from only the projection of the cosmetic gynecology, or you can say the beautification of the intimate part. So it's very difficult for we ordinary gynecologists who are doing right and left practice to have the patient who only comes for the beautification of the organ. But understanding how it is helping the woman for their functional problem, their regenerative problem, giving the whole subspecialty a clear name, which can be understood by everyone, and it has a proven medical science behind it. We had in detail discussion on the vulva yesterday. Vulva is a forgotten pelvic organ. Since this speciality, we have a interest in vulva which is risen. And yesterday, just to recap, we have learned about all the peels, Botox, fillers, what they are, how we are going to use it for the vulval bleaching or labial augmentation. Otherwise, also these things can be used on the face, and face has a skin and vulva has a same skin there. So whatever we can use on the face, we can use on the vulva. That is the that we have learned from the dermatologist and copied in our the intimate part. So the second part of this, we have talked about the vulval dermatosis. As a gynecologist, although vulva is a part of our study, but we never focused much on the vulva, and mostly it is sent to the dermatologist. But a few things are which are very common. It is better if we understand and treat by ourselves, like the genital warts, LSA, molluscum contagiosum. These things we can easily handle with the energy-based devices. Then we have learned little bit about how to do the procedures on the vulva. All procedures shown by Dr. Mayuri. Many operative videos are also there. I think you all are very much benefited by that. And we have touched even the penetration, pain penetration, sexual disorder also in the form of vulvodynia and the vulvo, and vaginismus. So completely covering the vulva was the motto for the yesterday. And today we are moving forward. The last part of the So that is the laxity, vaginal laxity, and the SUI. And then we have a panel for that. In panel, you are going to have the complete overview of the all 3 days what we have discussed from the all stalwarts who has joined all 3 days. So with this recap of the yesterday, I asked the team to go for the pre-test for the day. Gauri?
हाँ मैम क्लिक पोस्ट कर
Yeah,
दिया
please.
गौरी टाइमर भी चालू कर दो.
Hello. Hello. Dr. Agini, am I audible?
Yes, yes.
I'm sorry to interrupt. For quite some time, I have been muted, and that is why I could not join. But please carry on with the program. I am attending the ISAR Gujarat conference at Rajkot, and so I cannot spend more time with you. I believe the question answer session is going on, right?
Yes, yes, sir.
Please go ahead. All the best to you and all the participants. Thank you.
Thank
Bye
you.
bye.
Thank you so much. Thank you so much.
Bye.
Last 2 minutes. Yeah. Gauri, I think we have finished the pre-test.
Yes, sir.
Yeah. Ragini ma'am, are you there?
Yes, Apurva, I'm here, very much here.
Yeah. Yeah.
Good to
Yes,
see
ma'am.
you. Now I'm relaxed.
So much. Absolutely, ma'am. Thank you so much. Yeah. Ma'am, should we start? Because
Please start.
Sarita
Please
ma'am is
start.
in emergency. So
Yeah,
probably
yeah,
she will join
you
late.
will start take over, conduct the whole
Okay.
program.
Okay. 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 So after these 2 days of exciting lectures, different topics, and really entirely different, teaching. Now today is the last day and the third day of our this online ICOG certified cosmetic gynae course. So I would like to invite all of you, and I'm, start the first scientific session. And I'm really very, very excited to introduce the chairpersons and all the speakers, because all they are so close to my heart, whether it's Poonam ma'am, Riddhi ma'am, Seema ma'am, everyone. So it's really being like मैं अपने घर पे कुछ lecture दे रहा हूँ. So thank you so much, and without wasting the time, now I would like to introduce the uh, like to introduce the chairpersons, and the first chairperson is Dr. Meenu Agarwal ma'am. Again, Meenu ma'am doesn't need any introduction. Ma'am is the immediate past chairperson of the Pune Obesity Society. Ma'am is the past chairperson of the Emerging Science Committee of FOXY. Ma'am is the Secretary General elect of the International Society of Gynae-Endoscopy, joint treasurer of Maharashtra chapter of IFS, and whatnot. Ma'am has uh, a lot of award in her credits, and a very humble and very sweet. Thank you so much, Meenu ma'am, for joining and for sparing your time. Second, I would really very delight to introduce my mentor, Dr. Neeraj Jadhav, sir, just immediate past chairperson of the Sexual Medicine Committee, FOXY, which is right now I am heading. Sir is the past vice president of the Rajkot Menopause Society. Sir is the past secretary and president of the Rajkot Obesity Society and whatnot. Thank you so much, sir, for joining and giving your precious time. Our next chairperson is Dr. Binal Samen, again a very sweet senior and friend of mine. Ma'am is the past president of the Baroda Obesity Society, also the past president of the Menopause Society of Baroda, and at present she is heading the Public Awareness Committee of National IMS, and she also received the Best Committee Award of the IMS for the Public Awareness Committee. A lot of awards in her credits. Our next very dear Dr. Bharti Maheshwari ma'am, again doesn't need an introduction. Ma'am is the at present the president of the Muzaffar Nagar Meerut OBG Society and past chairperson of the MTP committee Foxy. Ma'am is the professor and head department of OBG OB-GYN at Muzaffar Nagar Medical College. Thank you so much, ma'am. Welcome. So our next chairperson is again very dear Dr. Ranjana Khanna ma'am. We all know ma'am. Ma'am is the past president of past vice president of the Foxy 2017. Ma'am is the ICOG governing council and founder president of the Prayagraj ISOPAB and whatnot. So thank you so much ma'am for coming and for giving us your valuable time. So I would like to invite our first chairperson, Dr. Minu Agarwal ma'am, to please introduce our first speaker, that is Dr. Seema Sharma ma'am. Minu ma'am, are you there?
नहीं सर, मैम अवेलेबल नहीं है यहाँ पे.
Available nahi hai. So Neeraj sir?
I can Apurva, I can introduce Dr.
Yeah,
Bharti
sure,
here.
sure, ma'am. Yeah, ma'am. Please, ma'am.
Okay. So first of all, huge congratulations that such a unique program on this is a special topic by ICOG, Foxy and whole team and especially Dr. Narendra and Dr. Agni ji for coordinating such a wonderful program. So for next speaker, I am just going to introduce Dr. Seema Sharma. She is the director OBGYN Apollo Cradle, Motinagar, Delhi. She has a special interest in sexual medicine and she has authored 4 books, as well as she has contributed lots of chapters, and she is the co-founder of NGO also, and she has a regular on media and in the public awareness program. So now to Dr. Seema Sharma for next very important topic. Yes, Dr. Seema.
Thank you very much, ma'am, for the kind introduction. Thank you, Ragini ma'am and the ICOG chairpersons for allowing me to be here. Can you see my screen?
Yes, ma'am.
Yes, ma'am, it's visible. Please make it full screen, ma'am. Yeah.
Okay. So I am going to talk about stress incontinence, the non-surgical treatment. What is stress incontinence? Is by definition, it's an involuntary sudden loss of urine secondary to increased intra-abdominal pressure. Very, very important entity for us to understand because it basically accounts for more than 50% of all cases of urinary incontinence. And it is estimated that 1 in 5 adult women have stress incontinence sometime or the other in their life. Now, why does it happen? What happens in stress incontinence? So basically, a woman is losing little amount of urine when there is an increase in the intra-abdominal pressure. There are 3 things at play here. One is an increase in the intra-abdominal pressure. B, the sphincter muscles, as you can see in the diagram, the sphincter muscles otherwise should be contracted when the bladder is filling. You see, bladder is continuously filling. Kidneys are producing urine, it is getting stored in the bladder. Now, the sphincter muscles, when they contract, they keep the bladder inside this, they keep the urine inside the bladder. So either the sphincter muscles are lax, or when their pelvic floor muscles are lax, these are, along with the increased abdominal pressure, the urine can leak. So loss of support we commonly see when a woman has had a normal delivery. We've had a bad episiotomy, not really bothered to increase her tone later on. There could be connective tissue disorders. There is an increase in intra-abdominal pressure when she has constipation, when she's training, when she's also doing weight training. These days, a lot of people young people want to do weight training, but they're doing it in the abnormal standing position. If they're doing straining, putting a lot of pressure on the bladder, and the bladder is not able to hold on. And the common complaint is that, well, when I use the gym, I leak. Also, some people also have a genetically weak collagen tissue, which causes stress incontinence even at a younger age. A lot of connective tissue disorders are there, or there could be a neuromuscular damage, as also in pelvic surgeries, or like I said, congenital weakness, congenital neurological disorders. So these are the 3 important points that we need to keep in mind when we have a patient who complains that there is leakage. Patient says, well, there is slight amount of leakage when she coughs or sneezes, or even when she gets up from bed, depending on the grades of stress incontinence that we will just talk about. But we must keep it in mind that sometimes, patients don't really give us the exact history that they are leaking urine because of increased abdominal pressure. They would just come to us with a history similar to UTI. So they say frequency is there, and I'm like, just about to reach the bathroom and I leak. We need to really find out what is happening there. So when we talk of management, we need to talk about history, examination, investigations before we actually formulate a treatment plan. And we need to formulate a treatment plan to individualize the patient, not that same thing will go on for everybody. So when we are asking about history, when she walks in, of course, the history of presenting complaints, when did it start, what was the index event when she started having this, how much is the amount of urine that she's leaking, how many times she's using the bathroom, what is the water intake like, how many caffeinated drinks, comorbidities, normal deliveries, surgical history, all of that, of course, we are going to take in the history. But so many times when we are asking questions, patients are not really ready with ready-made answers. Like if you ask how much is the quantity of urine you're leaking, she may not really know. So it is best to give her a voiding diary. We tell her that, okay, you go home and note down whatever exactly, right ad verbatim, like whatever. If you've had a glass of water, please mention how many mLs. If you've had a tea, coffee, please write down in that. For 48 hours, she needs to record her water intake, all the drinks, how many times she's been to the bathroom, how many times she's leaked with coughing, and etc. This basically allows her an overview of what is happening in her life. Now, this was history. Now, coming to examination. Now, when we make a patient lie down on a couch and ask her to strain because we want to demonstrate a stress incontinence, and we are focusing on the urethral meatus, we sometimes really don't, most of the times actually, we do not find anything dribbling out of the meatus. The reason is patients will get very conscious, when you're asking them to strain. So they are contracting their muscles involuntarily to avoid the embarrassment of leaking in front of you. But she's given us a complaint. So whether or not we can demonstrate, doesn't matter that, whether we can demonstrate it or not at that particular point of time. One point I want to emphasize here is when we are examining a patient, we must notice what is the status of her perineal muscles, perineal connective tissue. Is it atrophied? Is it normal looking? Is there any infection? And also urethral hypermobility has to be noticed. Now, traditionally, we have all been taught, okay, put a Q-tip and, see how much the urethra moves when she's straining. But practically in our OPDs, we're not going to really put a Q-tip. So when we are asking her to strain and we are looking at the urethral meatus to check the urinary dribbling, we must also see how much the urethra moves. If it is more than 30-degree elevation with stress, when she's straining, there is an element of urethral hypermobility that we must make a note of. Then comes the investigations. Urine routine and culture, of course, we need to do for all patients, irrespective of her complaints, whether it is stress, whether it is mixed, or whether it is urge incontinence. Infections can exaggerate the symptoms of SUI and need to be treated before you actually embark on the journey of treatment of stress incontinence. Another thing that we emphasize is a post-void residual volume. What is post-void residual volume? Is how much is the amount of urine that is left behind in the bladder after she has had a normal continence episode. When she's gone to the bathroom, after she's come back, you can put in a catheter, measure the amount of post-void residual volume. But most of the time, we don't want to do that. So we leave it on the ultrasonologist. We send her for ultrasound and we tell her that, okay, you make your bladder full. Let's measure the amount of holding capacity that your bladder has. Then we ask her to pee. And within 10 minutes, we need to measure the post-void residual volume. In a normal person, it should be less than 50 cc. Now, post-void residual volume increases with age and also with urinary infection. So we need to keep it in mind that older women will have a higher post-void residual volume as compared to a younger person. So majority of books will mention different things, but less than 50 is definitely normal. Between 50 to 150 is a gray zone. So you need to assess accordingly to the age and individualize how much should be normal. But more than 200 is for sure abnormal and indicates a bladder outlet obstruction. Uroflow and urodynamics normally we don't do in cases of SUI unless it's complicated or a mixed SUI. So by the time we have had the initial history examination and the results of the urinalysis and the SUI, we need to have a clinical diagnosis of stress incontinence versus overactive bladder and the factors which are important for that particular patient, which may be contributing to SUI in her, or whether there are any coexistent pelvic floor disorders like a POP or an anal issue, which we need to correct along with that. Now, before we move on, we need to understand what are the grades of SUI, because these grades are important. Majority of the times when women come to us that, okay, when I am doing jumping jacks or I'm coughing and I'm sneezing, I'm losing urine, these are milder grades SUI. You know, when you talk of older women, you know, or you have a patient who says, "Meri mummy chal nahi sakti hai, to aa nahi sakti hai hospital clinic mein," but when she gets up from bed, she leaks. When she is lying down, there is no problem. So those are higher grades in contact. With milder stress, if the urine is leaking, this is a higher grade SUI. It is very important to judge the grade of SUI in a patient, because very higher grade SUI, you need to go in for a surgical treatment, and medical management usually will not be effective in her. But medical management should be started in all cases in the interim while you're preparing her for a surgery. So how do we predict the success of our medical management? In what patients you will say, well, medical management will work, and in which patients the surgical management will work? Couple of predictors which have been mentioned. One is, if she's old, she's postmenopausal, higher rates of success with medical management. She's educated, she's more able to understand your instructions, to do Kegel's exercises, to come back for follow-up, higher success. There is no previous pelvic floor surgery. There is lower incontinence volume and leaking episodes. There is lower grade of SUI, maybe 1 or 2, and lower post-void residual volume, that is between 50 to 100. These are the people who are more amenable to medical management. So we need to keep all these factors in mind when we are counseling the patient about treatment options. So there are a couple of treatment options. I'm going to take you through all of these one by one. So first is the lifestyle modification that we are talking about. Now, lifestyle modifications should be according to the patient. We have had 3 factors. If you feel that increase in the intra-abdominal pressure is the culprit, which I feel in Delhi, especially, people are coughing, people are having chronic bronchitis, air is bad, you know, they need to avoid the rest of the increase in abdominal pressure. They need to have a weight optimization. The place where I am practicing, it's a huge Punjabi population, so including me, a lot of people are very obese. Weight reduction is the first line management. Correction of BMI will not only reduce the intra-abdominal pressure, but they will also reduce the comorbidities. She needs to avoid constipation, chronic cough, and also weight-bearing exercises in standing position. These are very important. So anything which increases the intra-abdominal pressure should be pointed out to her, and it should be corrected ASAP. Second thing, a lot of women compulsively drink a lot of water. So she needs to have adequate hydration, but she needs to limit extra fluid intake. Like we said, 2 liters per day is enough. More than that, not needed. And if your urine is relatively light in color, you're having enough. So you don't have to increase and drink like a fish. And also before sleep time, 3 hours prior, she should withdraw and have less fluids. And also reducing the amount of alcoholic drinks and smoking, spicy foods, caffeinated, carbonated drinks, all these can be bladder irritant, and they can increase the stress incontinence that the patient has. Now, also we tell her to go use the washroom every 3-4 hours or 2-3 hours, depending on what her bladder capacity is according to her age. The reason is, when she empties out her bladder regularly, relatively, when the bladder is very full, it is more likely to leak, and more likely to leak larger volume. So she might get very uncomfortable when she sees all the urine dribbling on the floor and all her clothes are getting dirty, and she's socially embarrassed. So if she continues to empty her bladder regularly, she may leak lesser volume. Also, exercises are very important, but she needs to do low impact exercises initially till the muscles improve. And also we need to check if she's on any medications like Lasix, etc., which may contribute to incontinence, should be changed. And while we are telling her about the lifestyle things, we also need to tell her about the over-the-counter products which are available to hold like incontinence underwears, pads, and urine making devices for higher grade SUIs. Now, we have talked about the lifestyle modification. Coming to the second modification, that is your pelvic floor exercises. Pelvic floor exercises can be done by two ways. One is, of course, if the patient does it at home. That is your Kegels exercises. Now, it's an entirely different debate what that how to do and whether it is improving the patient or not. But we need to tell the patient to do some form of exercises at home. And Kegels are like vaginal contraction, anal contraction, 3 sets. Each set having 10 contractions lasting for 10 seconds. So in a day, on an average, if she does around 100 to 150 contractions, which is a lot actually for a patient, this is what we want as a clinician for her to do. But obviously, Kegels exercises have their own limitations, whether the patient is understood, whether she's contracting the right muscles, whether she's able to do, she remembers to do it every day. All those are problems. Now, second thing, what we can offer her is a functional magnetic stimulation. I've been using this chair fantastically well for the last 5 years in my clinic. And patient needs to sit on this. It has a plug which we plug onto the electrical switch, and this converts the electrical impulses into magnetic impulses using the eddy phenomena. And these, my machine gives a magnetic field of 3 Tesla, which is equivalent to any MRI machine. This is that strong a magnetic field. And this induces a supramaximal contraction. And it is believed that a 30-minute session on this chair, patient is sitting fully clothed on it. And we've had sessions, and I don't need to talk too much about it. So a 30-minute session gives a strength equivalent to 10,000 Kegels exercises. And it's an in and out procedure. Patient comes, sits on the chair, goes. And anybody can handle this chair. It has got pre-fed protocols and very simple to operate. Now, initially, different people will say different things, but I personally would say initially I tell them to come and sit on it 2 times in a week because I want the effect to show fast. If I call her weekly, by the time she comes next time, she's forgotten how it was last week. So, the results are very slow to show, and by that time results start to come in, they lose enthusiasm to come to the clinic. So initial first 5 to 6 sessions, I tell them to come bi-weekly, and then I move on to weekly sessions. But I also tell them maintenance sessions are needed if you don't do your contraction exercises yourself. Then we were talking about the bladder training. It's actually not bladder training, but we just need to emphasize that, she needs to empty out the bladder regularly. Bladder training is actually different for urge incontinence and mixed incontinence and for stress incontinence. Here, it is very much simpler. It is just that you need to tell her to go pee every 2.5 hours to 3 hours, even when she doesn't feel the need to go to the bathroom. Now, biofeedback and electrostimulation therapies are both methods to, I'm sorry for this. Biofeedback is basically all auditory and sensory signals that we can give to the patient to show her what kind of muscles she is contracting. This improves the pelvic floor muscle therapy results. And this is basically done by physiotherapists. So I had just put it here. Then coming to electrostimulation, again, there are 1,000 ways to do electrostimulation of the pelvic floor. One important thing that has come up now, I was going through the literature, is via acupuncture needles. So acupuncture needles are put on the back and the bladder area, the nerve supplying the bladder area. 30 minutes to be done by an acupuncturist weekly for 12 weeks. So 3 months, 30-minute session. And then monthly maintenance sessions have also given very good results with stress incontinence. Now, coming to what gynecologists can do apart from lifestyle and pelvic floor exercises. Now, pessaries are very, very underutilized for stress incontinence. We know there are more than 100 types of pessaries available in the market, and we constantly use them for pelvic organ prolapse, but we don't utilize it for stress incontinence. But literature mentions that a pessary trial should be offered to most women who have urinary incontinence. The only exceptions is when there is foreign body infection, patient is not willing, she's not able to remove the pessary. These are the contraindications to pessary use. But pessary is best used along with in combination with other things like pelvic floor muscle therapy or surgery. We have all used ring pessaries, which are commonly used, and they should be the first line therapy to be used. Now, we basically divide pessaries into 2 types. One are support pessaries and one are space filling pessaries. Support pessaries are the ring pessaries, which are just supporting the vagina and the organs, and they are used for milder grade. So what we normally, how do we decide which pessary to use? Is we do a pelvic examination. If the pelvic hiatus, the vaginal hiatus is like 1 to 2 fingers diameter, we use the standard ring pessary, which is effective in almost 70% cases. When the vaginal hiatus is broad, like introduces three fingers or even 4 fingers, then you need to use the Gellhorn pessary. This is meant for higher grade POPs and higher grade SUIs. Also, space filling pessaries, you can imagine that we used to give those betadine tampons in older time. We still do it actually for prostodentia patients, wherein we want to keep the prolapse inside. So this is like a tampon for the patient. It keeps everything behind till we go in for surgery. The space filling pessary I'm talking about. How does it help? How does the pessary help? It basically compresses the urethra against the symphysis pubis and elevates the bladder neck, and that's how it controls and reduces the stress leakage. Now, research says pessaries are very good. It improves 80% of prolapse symptoms, 50% of urinary symptoms, 40% of bowel symptoms, and approximately 50% patients report an increased sexual frequency and satisfaction with pessary use. But the problem is long-term usage is less. Most of the patients will discontinue, and all the long-term usage beyond 1 year is only 50%. Now, what if the patient also has a pelvic organ prolapse along with SUI? What do you use at medical therapy? Of course, pessary, but along with that, a pelvic floor muscle therapy instead of a pelvic floor muscle therapy alone. So combination should definitely be offered to patients who have persistent or recurrent SUI, or even if she's had a surgery, she has had a hysterectomy, medical management is now needed. So combination should always be given. Coming to medications. Now, medications traditionally have not been used for stress incontinence as much as they have been used for overactive bladder. Oxybutynin, miragabaron, tricyclic antidepressants, these are the category of drugs which increase, they attach to the muscarinic receptors in the bladder wall, and they make the bladder more quiescent, and they may help in increasing the urinary voiding volume once the patient goes to the toilet. Now, the new improvement which has come is in duloxetine and the use of estrogen. Now, duloxetine is a serotonin and norepinephrine uptake inhibitor. It is very good. It was traditionally used for overactive bladder, but now they say the effectiveness in stress incontinence is also 50 to 60%. But the problem is that duloxetine has a lot of side effects of GI, like it causes a lot of nausea, vomiting, loose motion, especially in older population, and it also increases suicidal thoughts, which is a huge problem which has not been considered in majority of the meta-analysis which has been done. So practically, we don't use duloxetine as a gynecologist. What we use instead is estrogen. Now, estrogen, again, we've been using for GSMs a lot. But how does it work? It basically it increases the tropism of the vaginal mucosa and also of the urethral epithelium. It increases the vascularity, which is very, very important for the urethral sphincter, and that's how it causes an improvement. Now, why patients don't find an improvement with intravaginal estrogen use is because estrogen has to be given for at least 3 months for symptoms of SUI to improve. So 3 months later, she will start noticing an improvement, and she can continue till as long as she wants it if there are no contraindications to topical vaginal use. Coming to energy-based devices, we've been hearing about energy-based devices on and on. We have lasers. RBM YAG is what I personally use in my clinic. Carbon dioxide, diode, radio frequency, HIFU, and plasma devices have all had their own shares of meta-analysis, and one everybody says my machine is better. The problem is actually people don't have 2 machines to really compare. So we are dependent on a lot of industry-driven data, which obviously will promote their own machines. But what I have been using is the RBM YAG, and it has a special protocol for incontinence, that is Incontilase, which works for correcting the stress incontinence. It also has a long intraurethral sphincteric probe, which can get inserted into the urethra, and it also improves the prophism of the urethral sphincter. So if remember the first slide where I had shown the picture, the urethral sphincter is at fault in a lot of patients, and there is no machine that is actually correcting the urethral part of it, the internal sphincter part of it. So this probe, the long probe, which has now been introduced by Photona, is very effective in correcting the urethral internal sphincter. So I will not come to the difference and all. The thing will become very big. We've been hearing about energy-based devices on and on for the last 2 days. Now coming to urethral bulking agents and PRP. This is another interesting thing that we've been hearing about. Now, bulking devices, gynecologists don't use. Most of the times, the urologist colleagues will be used. Either they will use intra-abdominally on the bladder neck, they will place injectable material, or they will go through the vagina. Lots of bulking agents are available: silicone particles, carbon beads, calcium hydroxyapatite, you name it, and it is there. Even PRP has been used as a biofiller. It's a reasonable option when there is nothing else available. Now, PRP, I want to take a special slide to talk about. Now, how does it work? Autologous PRP basically is supposed to increase the regenerative tissues below the urethra. It acts as a mid-urethral support and reduces hypermobility. So what we need to do is have around 4 to 5 cc of PRP. We can either inject it in the intersphincteric area or in the anterior vaginal wall. You go in 1 centimeter. The depth you have to gauge yourself depending on the thickness of the tissue. If she's a healthy person, maybe you can go in by 1.5 centimeters, but she's a thin, frail person, you need to just go in maybe even 0.5 centimeters, but 1 centimeter in, 0.5 centimeters in, 2 ml to be injected in the midline, and 1.5 and 1.5 on either side. This is the protocol for PRP. You may need repeated injections. Some meta-analyses have said it is very good. There was a set of 11 trials which said fantastic. Equally number of trials will say not effective. I have used PRPs a lot. I am very unequal. I mean, I haven't really had fantastic results, call it whatever, my preparation method or whatever, my older patients where the platelet quality was not very good. I am not very gung-ho on this, but this is another method available. But it is a better agent than other things like paraffin, bovine collagen, and hyaluronic acid because it comes from the patient herself. It's biocompatible, durable, non-migratory. It can also repair the injured ligaments which may have happened at the time of normal delivery. So it increases its use further. But just because we can prepare the PRP, the bulking agents should never be used as a first-line management. There have been trials head-to-head which have said, even if you're using it post-surgery, there has been a surgical failure and stress incontinence has happened, in that patient. But a repeat surgery may give 3 to 5 times higher continent rates, even if it has happened after a previous failed surgery. So as compared to medical management or PRP or bulking agents, repeat surgery still in good hands will give better results to the patient. So a take-home message that I would say is stress incontinence is very troublesome. It reduces a patient's quality of life. We need to start on non-surgical methods before the grades of SUI increase. Try and give combination therapies. And every patient, irrespective of grade of SUI, should be offered a trial of non-surgical treatments. And treatments have to be holistically planned for each patient, not because you have a laser machine or you have an Emsella chair, you will just do that. So you need to plan for the patient, give her individual care, and tell her what is best for her and give her the best. Thank you so much for your patient hearing.
Thank you, Dr. Seema. That was a very, very, very nice presentation.
Thank you.
I'm sorry I logged in late. I'm Dr. Meenu Agarwal from Pune.
Hi, ma'am.
Yes. Now with all these TVTs that are there, all the meshes, they are coming into a lot of scanning. So I think we will be left with more of holistic approaches and more of, other
Yes.
non-invasive approaches. So I'm sure your laser and your that non-surgical thing and with PRP, I think that will probably do a good, with good results it should come out with. So that was nice, very crystal clear presentation. Thank you. And thank you to Dr.
Thank you so much, Meenu ma'am, for joining.
Yes, thank you.
And I just want to tell all the delegates, if you have any question, please share it in the chat box. Our speaker will answer it directly in the chat box. Now, we don't want to discuss any question here because it will take time and we have a long program to go. So, and I also request all the speakers, please see the chat box. And if there is any question related to your talk, please answer them. So thank you. Thank you so much, Seema ma'am, for your wonderful presentation.
Thank you.
And next, I would like to invite Dr. Ranjana Khanna ma'am. Ma'am, are you there? To invite our next speaker, Dr. Poonam Mishra ma'am. Ranjana ma'am.
Yeah, I'm unmuted now. Yeah,
Yeah, yeah.
yeah. Can I have the CV?
Yes, ma'am. Yes, just 1 minute. Yeah. Is it visible, ma'am?
Yeah, actually I've joined with the mobile today, na. Yeah, I
Yeah.
would love to. Poonam Mishra is going to give the talk.
Yes,
Who's
ma'am.
going? Poonam Mishra. Okay.
Yes,
I
ma'am.
would love to invite Dr. Poonam Mishra, who's the director of Manas Hospital and Manas Gynae Cosmetology and Laser Center, Lucknow, secretary of Manas Seva Sansthan, president of Indian Society or Indian School of Aesthetic Gynecology. She is the chairperson, Cosmetic Gynecology, and member of Sexual Medicine Committee, Foxy India. So I invite you, Dr. Poonam, to deliberate on your topic.
Thank you so much, ma'am.
Thank you.
Thanks for this generous introduction, and thank you, Apurva.
Hardly
Thanks
generous.
a lot.
You are deserving.
Thank you. Thank you so much, everyone. Thank you, Ragini ma'am. Thank you, Naren sir. And thanks for giving me this opportunity to be here on this prestigious platform, ICOG workshop for cosmetic aesthetic gynecology. And the topic given to me is a very special to me. I have been always passionate about that. Yes, the non-surgical management of vaginal laxity. So the case is like every day in our practice, we are getting now patients are asking themselves that, ma'am, after 2 deliveries, I feel I'm loose. And is there only surgical corrections? So non-surgical corrections have got their very special role for those cases which are not that severe, where other modalities actually are of no use. And so we can go to these non-surgical modalities, and most of the machines and this PRP is going to be a repetition one. So I would be flipping very fast. But the fact is that indications are different. So the way we are giving and the results we are getting are different. So I'm going to share my screen. Just a minute. I hope it is visible. Is this Apurva?
Ma'am, it's only the, yeah, your screen is visible, ma'am. Yeah.
Yes.
Yeah, please
Thank
make
you so
it full
much.
screen. Yeah.
Yeah, I'm going to make it. So the non-surgical treatment of vaginal laxity, the topic has been given to you. I think it is full screen now. So here.
Yes,
yeah,
I
ma'am.
think it's full screen. It's full screen.
Okay,
at least I can see it.
Okay, thank you, ma'am. Thank you so much. So vaginal hyperlaxity syndrome, VRS, has been in use, vaginal relaxation syndrome. But I always prefer this word because with relaxation, contractility, and and relaxation is the property of vagina. That is a normal thing. Hyperrelaxation syndrome, hyperlaxity syndrome is something for which we are worried about. And patients are coming that, yes, now they are loose. Loose means something has become hyperlax. Lax is laxity, then contractility. This is the ability. And with Kegel's exercises, they train them to get the control over their pelvic muscles so that they may relax also. In cases of vaginismus, we train those patients to relax their muscles, not making it tight. So making it tight, making it relaxed is a property which a lady can master with the help of different exercises. But yes, she is bothered with the fact that with aging and with vaginal births, there is hyperlaxity. So vaginal hyperlaxity syndrome and vaginal tightening, the non-surgical procedures I'm going to discuss. So let's discuss about the life cycle of a female. She's born, she grows up, becomes a lady, then further grows, ages, and becomes older. Yes, this is a beautiful life. Yes, ma'am.
Can you change your display setting, because the 2 slides are visible? So if you can make single slide visible, it will
Okay,
be
sir.
good.
I see. Yes, sir. Just a minute.
On top there is a display setting above your right. No, not that.
Yes, sir.
Hmm.
Let me make it.
Yeah, now perfect.
Okay. Thank you, sir. Thank you for guiding. And this life cycle actually, when a female grows up, when a female becomes an adult one, she thinks about the marriage and thoughts go more personal. And because of that, once she is actually married, the life changes and becomes pregnant. With pregnancy, what happens? She is blessed with kids. Yes, the beautiful moment comes. But what happens post pregnancy? She's bothered. She's bothered with the extra responsibilities and other things. And yes, few more, the changes inside the pelvis, changes in the vaginal muscles, changes in the vaginal caliber and other things. So vaginal relaxation syndrome, the hyperlaxity syndrome, which gives her the loose vagina, and tight versus expanded, the relaxed vagina, which we get because if she is giving birth to a 3.5 kg baby, definitely it is just like a spring. It is stretched and it recoils. It stretches and recoils, but the time comes when it stretches and doesn't recoil to its previous shape and position, and there she is suffering from some sort of laxity inside the vagina. And with that comes in many families the disharmony, and patient becomes less orgasmic. She is worried for her sexual pleasure also. Now she is not getting that amount of pleasure which she was finding in her pre-pregnancy state. So everything changes, and even the partner, most of the times the patient herself is worried, but if she is discussing it with her partner, he also thinks that she should be a bit tighter. So vaginal relaxation, laxity, hyperlaxity, why does it happen, and what an underreported problem, one of the most common health issues, yet far too overlooked and left untreated? Why do we need the treatment? Because what are the causes? Causes are vaginal trauma due to vaginal deliveries, as I said, aging. As she ages, the collagen changes. Her collagen, the quality of collagen, type 3 changes into type 4, type 2 changes into type 3. So the recoiled collagen actually are decoiled, and the quality of the skin, the elasticity of the skin actually is gone with aging as well as with because of the traumas. Excess weight is also a causative factor. High rate of sexual activity, but yes, this is debatable. This is not thought to be a problem for hyperrelaxation syndrome because this is actually a sort of exercise. Certain sports like running, horse riding, and other things. Genitourinary syndrome of the menopause, a big problem in cases of perimenopausal females. Genetic disorders also, because the quality is actually transmitted to her heredity. It is hereditary. Genetically, she gets the quality of skin what she is going to have in her lifetime. And the congenital defects are also there, because of which there is loose vagina. And decreased collagen production, as I told, is the skin and mucosa of the vaginal wall leads to the feeling of slackiness in the vagina. So changes also occur in the genital area, including a loss of functionality as well as the aesthetic look. And here it interferes with the women's sexual functions and leads to dyspareunia, decreased libido, decreased desire, decreased arousal, decreased orgasm, and symptoms of perimenopausal period significantly influence the quality of women's life. Genital aging can be a reason of female sexual dysfunction. So female sexual dysfunction thus can result from trauma and impaired healing due to natural course of life, childbirth, menopause, aging, as we discussed. So what is happening? She is having a loose vagina, which is leading to the female sexual dysfunctions, which is causing the marital discordance also. And different facts are also there. In 1917, life expectancy for men and women were 47.4 and 54 respectively. women in the post-menopause in the world were that much in 2016, while 1.1 billion in 2025 they are going to be. What does that mean? That means that the number of perimenopausal ladies or the menopausal ladies is going to or is increasing and is going to increase exponentially in future. Vaginal aging prevalence, we are getting 50% of postmenopausal women are there. 25% of them are under hormone replacement. 15% of premenopausal women are there. 50 to 70% of breast cancer survivors are there. So they are survivors, but they are suffering. Their skin quality because of the chemotherapy and radiotherapy has changed. So they have got a life expectancy has increased, but the quality of life should also be better. So this is our motto. 77% of women in ABV avoid their partners. So all these things are like creating problems in postmenopausal females or perimenopausal females. So what could be the effect of hyperlaxity and the decreased quality of collagen is lack of confidence, lack of pleasure. One had once enjoyed disharmony in marriage, associated urinary incontinence, as Dr. Seema discussed so beautifully, more susceptibility for vulvovaginal infection due to atrophic skin, leading to intractable burning and itching. So these could be the conditions because of the deteriorated quality of collagen. Comparative anatomy is there for the sexual problems of a female, the penis and the clitoris. And this has been found that clitoris is much more sensitive. It has got double the number of nerve endings. So, and the anatomy of the genitourinary, the pelvic diaphragm, which separates the abdominal organs from the pelvis. And it is a very strong structure, which actually bears the burden of whole abdominal as well as the whole body's straight position. Everything is borne over its flat surface only. So what happens once it is damaged, once it is weakened, all its functions of handling, holding over the organs which are dependent over it, actually the whole equilibrium changes. These are the multiple layers of perineum as well as the pelvic diaphragm, the special muscle, that is the levator and eye muscle. So everything because of the birth trauma as well as because of the aging. Role of pelvic floor muscles are supports pelvic organs against gravity, increase intra-abdominal pressure, maintain anorectal angle, relaxation for defecation and contraction, prevent incontinence, urinary and fecal. In females, supports and gives tone to the vaginal wall. This is the function of pelvic floor muscles. And once they are damaged, what is going to happen? See, all these functions are going to be deteriorated. Allow for opening of the pelvic floor to accommodate excretory functions and intra-abdominal pressure, has an inhibitory effect on bladder activity, assist in unloading the spine, assists in pelvispinal stability, and contribute to sexual arousal and performance also. So cosmetic gynecological procedures are not just serving aesthetic purposes, but they have got high functional aspects also, these procedures. So that is why we call the whole this academia to which we belong is actually more in favor of aesthetic gynecology, because it is not only the cosmetic improvement, it is also the functional improvement. So the treatments could be medical or surgical, invasive, least invasive, or non-invasive, the surgical parts. So surgical parts are not going to cover. Medical treatment can be there, the herbal creams and sprays, estrogen, topical and systemic, HRTs, hormone replacement therapies, and treatment of the underlying infections. So non-invasive treatments, in non-invasive treatment to strengthen the vagina is Kegel's exercise. The Kegel's exercises, when performed properly, they give control over the pelvic muscles and perivaginal muscles. There is electromagnetic chair, which is high FIM chair, the high intensity focused electromagnetic chair, on which if a female or a male also, this helps for the strengthening of pelvic muscles of males also. So it helps for the treatment of erectile dysfunctions and premature ejaculation, sort of male sexual dysfunctions also. And if a female sits over it, it has been said that 11,000 Kegel muscles are there in a half an hour, and still the process is going on, still the data are coming, how much effective these expensive machines are and how much effective those lasers, radio frequency and other things are. But yes, patients are coming back and they are giving the review that yes, I am benefited. The fact is, the question is asked how long it is going to stay. So there I always advise that once we are giving some sort of treatment to you, the aging female, and your age is reversed, think that you are 5 years back to your present age. But from the next moment you are aging. So once again, the aging is continuing, and after 5 years, you will be in the same stage. So you will have to come back to the aesthetic, your cosmetic gynecologist or your aesthetic gynecologist for further treatments. So this is the gist. Least invasive treatments are PRPs, fillers, PRP, which is full of growth factors, the patient's autologous thing, the patient's own capacity to induce the healing cascade. And that is why whatever body does herself in 6 months is going to be accelerated, accentuated with the help of this PRP, and the whole vagina gets modulated, the neocollagenosis occurs. That is why this PRP helps, so that the body's own healing cascade, body's own revitalizing capacity is accentuated. Fat grafting, autologous fat grafting, the patient's own fat is taken and put inside the vagina, the empty spaces, and that is how the volumization is done around the vaginal spaces. And fillers can also be put over there to make the caliber shorter, narrower. Silicone threads or PDO threads, they are put inside the vagina in the way as we are doing the encerclage around the cervix. And here what we do, we go submucosally from the lateral wall to the posterior wall to the second lateral wall, the opposite lateral wall. We don't go anteriorly because anteriorly there is bladder. So, and if the patient is having rectocele, so we can't go much inside, but lower 1/3 of vagina, which is more sensitive, which is more sexually active, can be narrowed with the help of threads. And stem cells and regenerative medicine can be applied, the use of PRP as well as the stem cells and the exosomes and other things, and energy-based devices which have been discussed till now. The surgical parts are different plasties, which is going to be discussed further. This is not my part. So what is PRP? PRP was very well discussed by Dr. Seema Sharma, also my previous speaker. The PRP is platelet-rich plasma obtained after centrifuging whole blood. PRP is autologous biotherapy used for its healing properties. So patient's own blood is taken, centrifuged, and then whatever we get, the red erythrocytes settle down, and the upper plasma, the upper 2/3 part is platelet poor plasma. Still, it is full of growth factors. So we never ever actually advocate to throw away the platelet poor plasma, because it is rich with growth factors. So we utilize that also. But specifically where the treatment is needed, we put the platelet rich plasma, which is the lower 1/3 or less than that. It has been found that PRP injections are promising non-surgical options for female sexual dysfunctions, lack of lubrication, stress, urinary incontinence, which had been taken care by Dr. Seema Sharma. So the lack of lubrication is also a part of GSM. There also it helps, this PRP application, and female sexual dysfunction by actually remodeling the vaginal mucosa as well as the lower vaginal muscles. So we give orgasmic shots, we give G shot with the help of G spot augmentation, with the help of these PRP, this PRP. And PRP is safe, completely autologous, flows in the tissue. It doesn't aggregate at the point where it is given, other than fillers. Fillers, once wherever they are applied, they have to be spread with the help of your fingers. They have to be manipulated, otherwise they will make a globule wherever they are injected. But yes, they volumize. Wherever they are injected, they volumize the targeted tissue. And this is the fact that PRP is the best thing. This is fillers. Fillers are hygroscopic. They bind water 1000 times the volume of its particles. So it swells up. So wherever they are applied, they swell up and they just consume the evacuated, the vacuum, whatever has been generated because of the lack of the tissue. How fillers help? Once they injected, they hydrate the skin and mucosa, they restore elasticity, what we need for the vaginal relaxation syndrome, for vaginal tightening. Texture and tone is improved. This is also needed in cases of hyperlaxity. Provide cushioning effect and aesthetic enhancement and youthful appearance. Now, energy-based devices. Devices are CO2 laser, erbium YAG laser, diode lasers. These days are in vogue. Radio frequency, high intensity focused ultrasound, and carboxytherapy. So all these kind of energy-based devices we are utilizing for vaginal tightening. Their aim is to make the recoiling of collagen, because of which the contraction is there. Neocollagenosis, newer collagen is formed. Growth factor infiltration. Once it is injected, it actually accelerates the healing cascade. So growth factors from surrounding tissue, they come to infiltrate in the targeted tissue. They revitalize and restore elasticity and moisture of the vaginal canal. That is what we need in cases for tightening the vagina. So skin regeneration process after fractional CO2 laser here. Diode laser is also being utilized these days, but we have got the results over here. See, immediately after laser, there is the recoiling more, and then the whole skin is actually treated and the whole histology changes. Thermal neurogenesis also occurs, and that is why the sensation of the targeted part is also actually enhanced. Lasers, they could be of ablative and non-ablative types, and wherever they are put, they do the remodeling of the surrounding tissues. This is something which I got from my dearest Vidya Pancholia ma'am. And this is that before the treatment and after the treatment, the whole angulation of the urethrovaginal angle is actually enhanced. And the urethral angle in MRI, the hypermobility of urethra, the cases where SUI is there, the angulation is actually reversed and the patient gets better. This is a slide where different receptor. This is the slide where the different penetrability of different energy-based devices is there. And according to that, you can modify your treatment, what kind of treatment you need, what kind of depth you need for the treatment of your own patient. So you can customize your patient, you can prioritize, and you can personalize the whole treatment. So this is HIFU, high intensity focused ultrasound, where ultrasound machines are generating the thermal energy and utilizing for the remodeling of the surrounding tissue. And everywhere there is collagen remodeling, regeneration, neoangiogenesis, newer molecules, newer blood vessels are formed, fine blood vessels. And neovascularization, as I told, growth factor infiltration, vaginal lubrication is there. And radio frequency devices are also there. They also do the same heat. Only the modality is different. The laser is different. The radio frequency is different. And ultrasound technique, they actually, at the end, they all provide the thermal energy, the controlled thermal energy, which is being utilized to treat the surrounding tissue. So collagen and elastin.
Your time is up.
Okay, I'm just finishing. Everything is done. So outcome of all these treatments is narrowing and reduction of vaginal canal diameter. And this is what we need for the treatment of vaginal laxity, thickening of mucosa, strengthening of vaginal musculature, improvement in urinary continence and overactive bladder. Further improvement is observed in the following days, linked to the regenerative process induced by tissue denaturation. So controlled inflammation is there and controlled healing of this process by the surrounding tissues. And yes, surgical part is going to be taken care of by my next speaker. Thank you so much.
Thank you so much, Poonam ma'am. Your lectures are always an eye-opener for all of us. Thank you. Thank you so much. And all the delegates, if you have any queries, please send your queries in the chat box. And ma'am, can you please answer it in the chat box only, Poonam ma'am, so that we we save the time. Before that, I would like to invite my mentor, Dr. Neeraj Jadhav sir, to introduce our next speaker, Dr. Riddhi Shukla ma'am. Ma'am, first, please unshare your screen so that I can share your CV. Riddhi ma'am.
Yeah, actually, I was not able to unmute. I just wanted to give the closing remarks. Yeah, I was not able to unmute. So the thing is that Dr. Poonam gave a very nice insight into this. And as matlab, actually, we are quite ancient, should I say, gynecologists now. But we have been doing advising Kegel exercises and perineal tightening surgeries we have been doing also. But this has come up as a total new field altogether. So it is very heartening, and nowadays, especially because of the longevity and females becoming more and more conscious about themselves. So I think this is a very good branch. And Poonam, that was a wonderful talk that you gave. Thank you.
Thank you, ma'am. Thank you so much.
Thank you. Thank you so much, Ranjana ma'am, for chairing session. And thank you so much, Poonam ma'am. So Neeraj sir, can you just please introduce our next speaker?
Yeah. So it's my privilege to introduce our next speaker, Dr. Riddhi Shukla. I am so proud. She is the pioneer of the cosmetic gynecology in Gujarat. She is the director of the Arogya Specialty Hospital, visiting consultant at so many hospitals in Ahmedabad. She is founder of the Nari Health Cafe, and the founder of the Women Vitality and the Vulva Clinic. So she is going to talk about the surgical management of the vaginal laxity, as we already heard from Dr. Poonam about the non-surgical part. Now we are going to learn about the surgical management. So over to you, Dr. Riddhi. Stage is yours.
Thank you, Neeraj bhai, for a generous introduction. I would like to thank ICOG, especially because taking cosmetic gynecology for as a training module for 3 days, and we have been seeing that since last 3 days, we have seen there are more 300 participants. There is a very huge change what we have seen. Most congratulations to Ragini madam, what I call her. She is the Bhishma Pitama of cosmetic gynecology because she has been trying hard since so many years. And Dr. NM sir, because sir has contribution to almost each and every field of gynecology. और जब उन्होंने एस्थेटिक गायनेकोलॉजी का हाथ पकड़ लिया तो हम उसको आईसीओजी ट्रेनिंग कोर्स के लिए लेके आ गए. सो थैंक यू एवरीबॉडी. व्हाट वी हैव सीन दैट जब हमारी कहीं पे भी वर्कशॉप होती थी तो हार्ड 10-15 लोगों को भी इकट्ठे करने का मुश्किल हो जाता था. ऐसे डेज वी ऑल हैव सीन एंड आई एम वेरी प्राउड दैट सिंस लास्ट 3 days there are so many participants. So not wasting much of a time, what I would say, start with the surgical management of vaginal laxity. Vaginal laxity is defined as a sensation of vaginal looseness which may develop after pregnancy, delivery, or maybe some pelvic surgeries or because of menopause and aging. It is a complaint from a vaginal looseness. It is a very poorly investigated symptoms of pelvic floor dysfunction. We have seen that anatomy of pelvic floor, functions of pelvic floor, so pelvic organ prolapse or some other SUI, these all are the issues which do come to the surface. Of course, they are also unspoken issues, but they are positively treated by gynecologists. But vaginal laxity is some symptoms which is very common with underreported incidence of as high as 38 to 40%, and it has to be differentiated with pelvic organ prolapse. What I usually teach in all my training program is that it is very important that you examine the intimate area, vulva, vagina very carefully, that what you are going to address, because many of the time we have seen that we do fail to recognize that what is the problem. Etiology, I may not go into the detail because Poonam has very nicely explained about everything, but these are the common etiological factors: pregnancy, childbirth, trauma, past history of pelvic surgery, and aging and menopause. These are something which is unavoidable in any of the patients. Looking to the pathophysiology, we all know there is a strong association with pregnancy and childbirth. There is overstretching of vaginal wall and introitus during the vaginal delivery, causing the microtrauma as well as the overdistension macrotrauma of the tissue. And this can be the reason for that patient is ending up the laxity syndrome, or the tissue which has got damage, it is not coming back to its original thing. A patient may present with the complaint of excessive looseness of vagina, sexual dysfunction, that is a reduced vaginal sensation during the sexual intercourse, and folding of labias in wearing the underwears or swimsuits, or patient may typically complain of something falling out or coming out of the vagina. As I said, that it is a very underreported. So we, being a female healthcare provider, it is very important that we have to positively ask the patients who have delivered vaginally that does she has some sexual problem, does she feel loose during the sexual intercourse, or the partner may feel looseness. It's not only the patient, but sometimes partner also complain that whenever he is inserting penis, he do feel that there is a lack of looseness. So there are various presentation can be there, and as Dr. Ragini madam has very clearly said, and we all have understood, that aesthetic or cosmetic is just not the aesthetic, it is a functional and regenerative problem as well. So these are the patients, they do come to you in day-to-day OPD, and we have to evaluate them properly. So usually evaluation, whether it is a SUI or a sexual problem or a vaginal laxity, it is very easy to use a questionnaire. There are pre-formed questionnaires available online, so you can choose one of them and start evaluating your patient. So whenever you are giving any treatment, whether it may be a pelvic floor or it may be a medical management or a non-surgical laser or EBD or a surgical, then pre-therapy questionnaire and post-therapy questionnaire will guide you whether she has improved or not. Of course, patient may tell you that clinically she feels better, but it is very important to assess the patient with the questionnaires available. History, when you are taking, of course, detailed gynecological history, medical history, whether she has some collagen disease, whether she has hypertension, diabetes, because these are the patients when you are performing any aesthetic surgery, the chances of healing, if diabetes is not controlled, then you may face problem. In sexual history, where sexual health committee is very well associated with this. So I would say the one thing every gynecologist or every healthcare person has to do is ask about positively sexual history. We are the people who has to ask women about that, do you face any problem in the sexual intercourse, or do you have any trouble in your sexual life? Of course, psychosocial analysis, the one thumb rule is the patient who has some psychological problem or a patient who have a over expectation, you don't have to touch those patients. Very important is a most bothering symptom. See why patient is with you, whether she has a sexual problem, whether she has a functional problem, or it's simply a aesthetic concern. If so, try to adhere to most bothering symptom first. If she has come to you for a sexual problem, of course you can ask for a SUI or some other problem, but try to resolve that problem first and then jump to the treating the other problem. This is a very important when you want to start practicing aesthetic gynecology, or I would say any practice, when you have to evaluate what is the most bothering, why she is there. Clinical examination, you have to do pelvic examination, and of course when there is a pelvic organ prolapse, you have to assess POPQ grading, complete urine analysis, whatever the vaginal surgery that we may not go into the detail. This is a routine vaginal laxity questionnaire available. This is a very simple one you can use. And when you are doing patient evaluation, this is very important. It has to be done in a standing as well as in the lithotomy position. General gynecological, psychological, and sexual evaluation, presence of any infection if it is there. What is important is the clitoris and bulbocavernous sacral reflex. When you touch the clitoris or a bulbocavernous muscles or a labia majora, there has to be a winking of anal tissue. So this is very important. So because as Poonam has rightly said, this is a very sensitive area. More than 800 nerve endings are there in a clitoris. So impact neuromuscular tissue has to be here, that which will give you a good result of any pelvic surgery or any vaginal surgery you are planning. So width of levator hiatus at rest and during contraction, you have to ask patient, you have to insert the finger and ask patient to tighten amongst your fingers. So this is how you assess the contractions of the levator hiatus and muscle tone of the puborectalis. Of course, you check for the bladder hypermobility or SUI if it is there. Very important is when you are examining, see, this is a intro test. So very important is you have to see the thickness and dimension of the perineal body. Sometimes you will see that it is a very thin skin tag is left and there is no muscle at all. So these are the important points. This will help you in what kind of surgery you are planning, whether you are planning just the colpopography or you are planning a perineoplasty or you are planning both the things. So this evaluation is extremely important. This is how you can plan your pregnancy or plan your surgery. So proper evaluation gives you a 50% result because you are confident that, okay, patient is having a very thin perineal body. These are the patients you post them a perineoplasty. Digital rectal examination for a rectal fullness, pressure of if there is any rectocele. Treatment options, we have discussed all the non-surgical and conservative EBD. Straightway we move forward to the surgical management. So indication, as I said, if you have examined patients properly, then you will come to know that it is only introitus is at fault. Then these are the patients you have to plan a perineoplasty. If it is an introitus plus lower vaginal canal, it is a loose, then you have to plan colpoperineoplasty. And then there is a pelvic organ prolapse is there, then you have to go for a site specific repair. See, very important, I would like to tell all the participant here is that the patients of aesthetic gynecology, they do come from your routine obstetric and gynec practice. Okay, it is a mindset you have to change, that you don't have to go out and find out that these kind of patient exist, and once you put up a board of cosmetic gynecology, they are going to come. These are the functional or a patients having a tissue damage, or that you do see post-delivery, aging or menopausal patients. They are already there in your OPD, and from there, by asking them a leading questions, you can take out those patients. And number of surgeries, see, you need not to do numbers of labiaplasty or number of perineoplasty. What is more important is that these are the aesthetic surgeries, these are the very refined surgeries. So even if you see a one patient in a month or a 2 or 3 months, you need to give them the best result. These are the patients, you know, they may bring the other patients. So don't go by the numbers. But whenever patient is there, you do examine them properly, try to evaluate with where is the lag, and then try to give your best result. These are the contraindications of any pelvic or vaginal surgeries. So coming to the surgery, vaginoplasty is a general term used for procedure that reshapes the vagina. This includes cosmetic as well as therapeutic surgeries, all elective surgeries, whether it is anterior repair or a P repair or a vestibulectomy or a perineoplasty, they fall under the one heading of a vaginoplasty, because here we are reshaping the vagina. In cosmetic gynecology, vaginoplasty has taken a more specific connotation because it reduces the caliber of vagina, either by EBD or either by a surgery. And there is so what is important is that along with the vaginal canal, you are plicating levator ani muscle also. So history, it would not say that it is something new. Cosmetic gynecology or vaginoplasty or these aesthetic surgeries are new. This has been performed since ages. Vaginoplasty was first performed since 11th century by the the physician called Tortula di Rigori, and there are various pictures of these procedures performed in the last. So these are not new. These are the old procedures, but we have to start doing this with the newer outlook. So this one very important surgery today I would like to highlight is a perineoplasty. It is a surgical reduction of the width of the perineum. It is called a perineoplasty. There is a difference between the Rafi and plasty. Rafi means you are just suturing the things. But when you apply the term plasty, that means you are giving a shape. It is a reshaping of the any tissue. So colpoperineoplasty or a perineoraphy, you are along with the suturing, you are giving a good shape also to that area. It involves the excision of the midline tissue, which is a spanning over the perineum because of the aging or a post-delivery, and lower posterior of the vagina, and then approximating that tissue into the center. So this is how you are dealing with the perineum. You are decreasing the width of the introitus or a perineum. In therapeutic gynecology, it is used for a reconstruction of pelvic surgery or sometimes excision of neoplasma. But in a cosmetic gynecology, it is mainly used for a two purpose. One is to deal with the introitus. So not just by restricting yourself to the posterior vagina, surgery of the perineum tissue is extremely important. And second is, when you want to give a shape to the labia majora or minora, which have expanded because of the aging, when you do a perineoplasty, the labia majora which were like this, they will converge into the center and they'll look more bulky. And because once labia majora looks more bulky, the minora will also start protruding inside. So this is one surgery which takes less than, I would say, 15-20 minutes. Is a very important surgery when you are giving or reshaping the vulva or external genitalia. Secondary, if it is absolutely for a purely aesthetic purpose, when female is filling legs vagina, that along with the vaginal lower third of the vaginal canal, you have to do perineoplasty. So I will explain then how it has to be done. It can be performed along with the colpoperineoplasty. It can be done rarely where vaginal laxity is not there. There is only a perineum laxity is there. Then it is a very rare but isolated perineoplasty can be performed. Vice versa, that is a complete misapplications. So perineoplasty basically defines any change in the shape of the perineum. So what is to be achieved? If you will see, when you examine introitus with your finger, you will see then there is a laxity or there is a thin perineum. So this is the tissue which is marked here. That tissue we are going to excise, and at the end of the surgery, this extra tissue is going off, and your end result is going to be this. So this will bring these labia which were lax into the center. It will make minora more prominent. It will decrease the introital region, so that patient who was feeling loose or lax vagina, they'll be treated in a better way. This is how we estimate. So what we need to achieve, this is a simple that when it is introitus is very lax 4-5 finger and we want to make it a 2 finger, this is the simplest calculation we do in every procedures. We are pre-operative and anesthesia is same as any vaginal surgeries. So marking is very important. Any aesthetic procedure, if your examination is proper, you are clear in your mind that what are you going to do in labiaplasty, where you are going to incise, in perineoplasty, which tissue you are going to excise, then proper evaluation, it makes 25% of your job. Proper marking, it does more than 75% of your job. So how you have to mark? So you have to measure when you put your 2 finger and you feel that these are the end point where you feel. So you just put 2 marks on this, and then marking are extremely important. 2 points at the introitus for the desired diameter you want. Draw 2 oblique line from this, and then you make U or V shape depending upon the width of the perineum. So this is how you have to mark in a perineoplasty. Plus you have to mark on the anterior anterior margin of the external anal sphincter, because this is the line beyond which you don't have to go. This defines your boundary, that posteriorly you don't have to exercise below this. So this is how for perineoplasty you have to do your marking. Surgical technique, once you have marked anesthesia, it can be either local or a GA or a spinal anesthesia. Once the marking is done, then clamps are applied to the hymenal ring. And then you excise this tissue. Can you see? You can use either scissor or electrocautery. If you have a laser, then you can use laser cutting. Basically, a vaginal rejuvenation is a very hi-fi term, but what was done was that excision of the tissue with the laser knife. This is how it is called a laser vaginal rejuvenation. So you can use your cutting instrument, whatever you are comfortable with. So this is how the whole tissue is cut. The clamps are applied to hymenal ring. Incision is carried out deep into the subcutaneous flap and create a flap of enough thickness. An incision can be made with surgeon's choice. This is how you excise. So again, as we all know, when we are doing posterior repair, we are creating the rectovaginal space. Similarly, the rectovaginal space is created. Vaginal markings are done in a triangular pattern. It's not just you are doing the perineum, but as much as the tissue, whatever you have marked here, either it is a view or V, same size U or V incision is made inside the vagina like this. If you can see here, the same amount of tissue has to be excised from the vagina. Yeah, so yeah, I will be done in 2 minutes. So length of the triangle tissue is there. It is cut, and this is how what we suture in a posterior repair. So vaginal closure is done from the vaginal apex, and with the non-locking sutures, the bulbocavernous muscles are identified and sutures. Perineal muscles are sutured and skin is sutured in 2 layers. When you are taking sutures, try to take 1 centimeter little bit lateral, because if knots are lying exactly into the center, so post surgery, if knots are there, then that can be a painful during sexual intercourse. So this is how these are the steps of perineoplasty. This is a very easy procedure. I would say that after this training, whether after ICOG course or any training, PRP, perineoplasty, these are the things which you can start practicing immediately from day 2. You don't need any special instrument or anything else. Just the mindset that when you want to reshape the vulval tissue, minora, majora, or the introitus, perineoplasty is the easiest surgery you have to do. Colpoperineoplasty, the same way perineoplasty and what we do in a posterior repair, this everybody knows, so I may not go into the detail, but this is how the posterior perineoplasty and along with that colpoperineoplasty is done. Levator plication is extremely important. As I said, they try to avoid taking non-absorbable sutures and also in the middle, because it might hurt during sexual intercourse. So post-operative care, same as any other posterior, any other vaginal surgeries. So these are the routine post-operative care, and these can be the end result. This is the result of a perineoplasty, and this is the result of a colpoperineoplasty, you can see. So I would say rejuvenation does matter in women, and it is their right. So make someone feel look better or younger or vital. This is what we women healthcare provider has to do. Thank you very much for patience hearing.
Neeraj sir, you have to unmute yourself. Neeraj sir, please.
Sorry. Yeah. Thank you, Dr. Riddhi. It was a wonderful deliberation on the surgical management of the vaginal laxity. But there, I would like to mention one caution. Whenever you are treating surgical management for the for the sexual dysfunction, just make sure you rule out the other causes of sexual dysfunction.
Yes.
If present just for the sexual dysfunction, don't go for the operative procedure, because sometimes you will do more harm, because some of the most of the time we are doing this such type of surgery in the perimenopausal and menopausal age group, as
This
we
is for
all
the
know.
vaginal laxity mainly.
Yeah. So we all know that vascularity in that age group is not that much good. So healing will be not that good, and sometimes you may land up in the dyspareunia in such type of patient. So choosing your patient wisely is very important, and it's very important to know why you are doing this procedure rather than how you are doing, or how to do any procedure. It's very important why you are doing this procedure in this patient. So that only question I would like to mention here. But it was a wonderful presentation.
Thank you.
Thank you. Thank you, Riddhi ma'am. Thank you, Neeraj sir. So we are coming to our next lecture for today by none other than but Dr. Preeti Zindal ma'am. And I think, Neeraj sir, can you just introduce Preeti ma'am?
Yes. Just make a full screen, Apurva.
Yeah.
So it's a privilege to introduce our next speaker, Preeti Jindal. She is an advanced IVF, recurrent miscarriage, high-risk pregnancy expert, cosmetic gynecologist, laparoscopic. So that means she is doing everything what as a gynecologist one dream. So she is the director of the Touch Clinic in Mohali, past president of the Mohali Obstetric and Gynecology Society. So welcome, Dr. Preeti, to deliver your talk. Stage is yours, Dr. Preeti.
Preeti ma'am.
You have to unmute, Dr. Preeti.
For giving me such a good opportunity. Can I share my screen now?
Yeah, sure, ma'am. Sure. Please go ahead.
Okay. So just opening my presentation. Can you see my screen?
Yes, ma'am. Please make it full screen, please.
Yes. All right. First, on the outset, I would like to thank the Foxy and Dr. Agni ma'am and everyone here for giving me this opportunity. And we have been through a marathon of 3 days and learning so many things. And now coming to the fag end of this beautiful webinar, one very interesting topic which is very, very close to my heart is the carboxytherapy. So carboxytherapy is another very important therapy which is available in the armamentarium of a cosmetic or aesthetic gynecologist. So when was carboxytherapy discovered? The French discovered this form of therapy in 1930s, and they found that bathing in waters rich with carbon dioxide had health benefits. In 1950s, a doctor introduced the procedure as a part of health spa treatment in Czechoslovakia. The therapy has been widely used in Europe since 1970s and became very popular in Brazil. And many of the celebrities from India used to go to Brazil for their stretch mark treatment of this therapy. So carboxytherapy is basically not an energy-based device. It is a therapy which is based on use of carbon dioxide. It works on the basis of Bohr effect. The Bohr effect is whenever there is hemoglobin lowers in the affinity for oxygen, secondary to increase in the partial pressure of carbon dioxide or decrease blood pH, what happens? The oxygen goes into the tissue. And carboxytherapy basically works on the reverse Bohr effect, that if the carbon dioxide is more at some particular area, then what will happen? The oxygen will go inside that area and the carbon dioxide will come in the blood vessels. So the principle of carboxytherapy is it takes advantage of principle of offloading of oxygen. When RBC reach any area of high CO2, oxygen is released and carbon dioxide is washed off through the blood. So basically where there is too much accumulation of carbon dioxide or dead tissues or oxidative stress factors, they are washed off from that area and oxygen is offloaded and that area becomes rich in oxygen, and this leads to the rejuvenation or regeneration of that particular area. Now, there are two effects, Bohr effect and the Haldane effect. Now, Bohr effect is decrease in the oxygen affinity of a respiratory pigment such as hemoglobin in response to decreased blood pH resulting from increased CO2 concentration in the blood. So, because of it, what happens? As the CO2 increases in the blood, the oxygen diffuses out. And Haldane effect is decrease in carbon dioxide affinity of hemoglobin in response to increased blood pH resulting from increased oxygen in the blood. So if the oxygen is more, the carbon dioxide will move out of that area. So Bohr effect occurs basically at the metabolizing tissue area, and the Haldane effect occurs in the lung. Bohr effect describes the release of oxygen, and the Haldane effect describes the release of carbon dioxide. The Bohr effect is effective under low blood pH, and Haldane effect is effective under high blood pH. So where they are used, the Bohr effect is caused by take-up of carbon dioxide at the metabolizing tissue and the release of oxygen in that tissue. And the Haldane effect is caused by uptake of oxygen in the lungs and release of carbon dioxide. So if we see where these therapies will be useful, they will be useful for the area specifically under the eyes, the dark circles which occur. So why the dark circles occur under the eye? The aging causes capillaries to become dormant, which reduces the blood circulation. So this deprives those cells of oxygen, which stop their ability to regenerate. So when you increase the carbon dioxide, the reverse Bohr effect will take place. So what will happen? Because of increase in carbon dioxide in that area, oxygen will be offloaded from the blood in that area and carbon dioxide will be picked up. And because of this picking up of carbon dioxide and other oxidative stress factors, the regeneration of that area takes place. I have used it a lot for the dark circles and even for the bags under the eye. For most of the people, when there are bags under the eye, it is believed that there is no treatment, but carboxy therapy works like a wonder, a magic to it. You give 4 or 5 sittings and we can see that the bags under the eye, they disappear. So evidence shows that carbon dioxide also kills fat cells by causing them to distend. The extra oxygen eliminates, fluid builds up in that area between the cells, and the skin is stimulated to produce more collagen, and collagenesis takes place. So if we see in this diagram, this is where it works, the carboxy therapy, the dark circles, the crow feet, then also in the stretch marks, and also it may be used to burn the cellulite also. Now, carbon dioxide gas is injected. There is expanding of the cells, the increasing of carbon dioxide gas concentration in the capillary vessels, and then the carbon dioxide moves away from that area. So carbon dioxide is used for treatment of cellulite, for fat, for stretch marks, for scars, under eyes, bags, and loose eyelids, and for rejuvenating the collagen cells. So if there is a stretch mark like this, then why does these stretch marks takes place? These stretch marks takes place because the elastin and collagen of those tissues, they break. And when you do the carboxy therapy for that area, you can see it is with a very fine capillary or very fine needle, you inject the medical grade carbon dioxide. Now, carbon dioxide is also used for laparoscopy, and it does not cause air embolism. So there is nothing to worry about it. It does not cause any harmful effect. And when the carbon dioxide is being introduced in the stretch marks, you can actually see that the stretch marks, they go in form of the branches and there are fibroses. If you see very carefully the stretch marks, initially they become pink in color and then they become white. And if you feel over the stretch mark, you will feel the skin is like a scar with a branching. So there are fibrosis takes place and fibrotic strands form between the different layer of the epidermis. So when you put this carboxy therapy, CO2 actually makes the path and breaks these fibrous strands, and you can actually see carbon dioxide traveling under the stretch marks. So it can be used in the orbital area, in the dark circles, wrinkles, and the laxity of the facial skin, or even in the breast, you can use it. On the tummy, it works very well, and for the cellulite burning. So as previous speakers, they told about the HIFU. Similarly, carboxy therapy also helps in tightening of the skin and cellulite burning. You can see this is one of my cases. You can see this is the stretch marks before and after. And the results won't occur immediately in the first go. Depending on how bad or how old the stretch marks are, you may require 3, 4, 5 sittings. An infusion of CO2 gas under the skin, it increases circulation and the collagen production. So this is how there are special machines, the carboxytherapy machines, which actually lead to warming up of carbon dioxide. Because of warming up of carbon dioxide, you cannot directly just take carbon dioxide and inject. So these machines, what they do, they warm it up to the body temperature, and then you inject it. It just takes 5 minutes for the under eye treatment. But because you are injecting it, you have to apply some local anesthetic like Prilox gel and keep it for 40 minutes, and then you can inject it under the eye or whichever target area, and it just takes 5 minutes, and the effect starts coming in next few days and weeks. So these are the places where you can inject: on the forehead, on the eye, under the eye, then in the stretch marks. So this is basically what is the carboxytherapy, and it has got beautiful effect, and we can start it immediately after the delivery and at any age, and there are no harmful effect, but just one has to be properly trained that you should not inject very deep. And only reason why not to inject very deep, because it can lead to bruising. So it has to be only subcutaneous area, and you have to tell the patient that there will be some swelling under the eye for 1 or 2 days, because CO2 gets absorbed in 1 or 2 days. And if they have to visit some function or something, then they can do it on the weekend so that the puffiness is not visible. So this is about the carboxytherapy. It's a very, very beautiful therapy, and anybody can do it after the training. And I would also like to invite all of you to be member of INSAG, which is Indian Society of Aesthetic and Regenerative Gynecology. And Dr. Ragini ma'am is our present president who has organized this webinar. I'm the general secretary. These are few numbers which you can contact. And also I'll take the opportunity to introduce you to different hands-on training courses which are being organized by different people. All the speakers here have been organizing different courses, and please do get trained in these courses and come and start doing this. All these therapies, HIFU, carboxytherapies, laser, all these are the things of present and future. We all need to do, and soon they will become part of our every gynecologist should be trained into it. Thank you so much, and thank you organizing team for giving me the opportunity. If there are any questions, I can answer, because I think I have finished very much in time. Thank you, Dr. Apoorv.
Thank you so much, Preeti ma'am, for the really this carboxytherapy is definitely not new, but it is newly introduced, and nowadays cosmetic gynecologists are using it very much. So thank you so much for giving us the insight. So after this wonderful lecture of the Preeti ma'am, we will move to the next lecture by none other than but our own very own Dr. Narendra Malhotra sir. So for introducing Narendra Malhotra sir, I would like to invite Dr. Meenu ma'am. Meenu ma'am, are you there? No. So, Neeraj sir, can you just do the needful? Neeraj sir? Okay.
It's okay, actually. I've been introduced in the beginning. So
yeah.
it'll save 1 minute for me.
Yeah, thank you so much, sir. I always that the brainchild Narendra Malhotra sir and Ragini Agarwal ma'am is the brainchild of this cosmetic gynae ICOG certified course. And thank you so much, Narendra sir, for bringing out this beautiful course. And I am very much sure we all are greatly benefited with this course. So thank you and welcome you, sir. Sir, yes, sir.
So I'm going to, can you see my slides and hear me clearly?
Yet not, sir.
Are there slides?
No, sir, it's not visible.
I think it just got cut off. I'll just share them again.
Yes.
So a very good evening to all of you. It's indeed a pleasure to see that so many people are interested and are attending this course of ICOG, which is absolutely free And I see that there are questions which people are asking about where to get the training, how to. So it has got a very, very, Agya slide.
Ji sir, आ गया sir. Sir, please make it full screen.
It is full screen.
Thank you, sir.
So training, wherever these centers are, you can have training. You can contact the INSAG. And of course, the ICOG will be soon recognizing training centers for training. And it is because the learning curve is very small, you need not pay lakhs and lakhs and rupees for training. So the training centers we are running every weekend all over India, everywhere. You can contact me. I'll tell you where the next training programs are, and go ahead. Well, today I'm going to talk about anti-aging. And when I say anti-aging, that we all have to age and we all have to turn 60, but we all want to look 40 and feel 20. That is it. Is it possible? I mean, is it possible medically and socially? Well, I went to Italy and took a bath naked in this pond with hundreds of people. This was the real fountain of youth. And it says whoever takes a bath naked in this with people, then they will remain young forever and drink this water. But that did not happen, unfortunately. You have to do it every day. So let's see what is aging. Let's go to the science. The science of aging is biological and chronological. Chronological is the number of years since when you were born. And biological is how your body and the stem cells have finished and you're aging biologically. We know that all our cells will need to be changed, and our skin cells change every 3 years, stomach every 5 years, intestine 7 years, and these rejuvenate or form a new cell. That is normal aging. It's all about the stem cell in your body. And we have a stem cell reserve. And this stem cell is a totipotent cell which will replace all these cells. And if your stem cells runs out, that is what is causing premature aging. Now, what is the stem cell governed by? It is governed by genetics and it is governed by epigenetics. So whenever our DNA gets damaged, the DNA cannot repair itself, and the DNA damage of that specific gene or that organ will lead to your aging. The chromosome has, as you know, short and long arm. The tip of the chromosome is known as the telomeres. Now, these are the telomeres which will contain all your genetic material. And here you see, and they are ATGC, 30,000 genes. And these are the reasons which are cause aging. If you have a long telomere, a big telomere, you're going to live much longer and you're not going to look older. If you have short telomere, then that's why some people age faster genetically. But this is triggered off by epigenetics also. So the telomeres get shortened either genetically or with the stress or with the inflammation and or with the external thing, like all the smoke and all where we can remain. And this damage to the DNA with the telomere will lead to damage to the organs, the tissues, and the protein, the mitochondrial dysfunction, the cellular dysfunction. Tissue will age, tissue will break, bones will break, the mattress will, and the organs will cause the disease, like the cardiac disease and all, and that tissue dysfunction will finally lead to aging and death. So we have setup which looks after 6 major areas of healthy longevity: your mental health, your cardiac health, your immunological health, your hormonal health, bone and muscle health, and mitochondria. Now see, if the telomeres were long, I have divided this girl into two. This side girl had long telomeres, her skin is still fresh, same age. And this one had short telomeres, you see the wrinkles and aging at the same age. So aging is because of telomeres. And aging will affect all the systems in the body: skin, body, vision, senses, musculoskeletal, renal, every organ is going to be affected. Why some people age faster? Because of genes, because of telomere, because of how they live. They live in factors of the environment which is unhealthy lifestyle. When they lived in the 1900s, the air was pure, but they were dying because of infection, not of old age. Today, it is the oxidative stress which is killing us. So reactive oxygen species is the one which will be killing us. That's why the antioxidant and reactive oxygen species have to be in a balance. If the ROS increases, your body suffers oxidative stress, oxidative damage, chronic diseases, premature aging, even cancers. And this will affect all the parts of the body, mitochondria, cell, Golgi apparatus, nucleus, and cause Alzheimer's, depression, insomnia, fatigue, migraine, hypertension, atherosclerosis, stroke, pneumonias, eczemas, dermatitis, nephritis, pancreatitis, diabetes, enteritis, arthritis, sarcopenia. So that is what the aging will bring about. So, and this is all because the cell is now under a lot of oxidative stress and has led to a lot of endogenous changes of enzymatic and non-enzymatic and exogenous changes. So we need to neutralize this, and we need to molecularly correct the cellular mechanisms of aging. So we need to test first. And we know it is in our genes, 23 pair of chromosomes, 30,000 genes. Only 1/3 genes are actually good exons, the rest all rubbish. And it was seen that these genes, the bad genes, are there in all of us, and it gets activated by environment, which is the epigenetic. The Chernobyl experience shows us that. So the Chernobyl nuclear incidents where the nuclear energy was released, and you saw that 10 years older these people became as compared to the others, because this caused the epigenetic change, caused the damage to their stem cells, and they could not replace. So aging is just not a law used, but it is a new stage of opportunity. And it is because of decrease of stem cells. So chronologically, you will age, and biologically, you will age because your stem cells are decreasing. And when they decrease, you're going to suffer from all the chronic diseases, which will finally lead to death. So that is how the immune system weakens. The weak cells cannot destroy the arising cancer cells in the others, and the immune system becomes autoimmune disease, and they start attacking your own tissue. So in this manner, the autoimmune diabetes, liver, cirrhosis, that all will develop if your stem cells get depleted. And all the body function repairs will not occur now. So now, can we reverse imaging? When we understand it, how can we reverse imaging? First, you have to try to increase your telomere. First, you have to test your telomere. So we now have a test available to us, which is taken from the blood smear on a little bit of or a saliva or a little bit of blotting paper, and you get a full telogen repair. Then we need to correct our epigenetics and environment and be free of chronic diseases. So aging is an issue, but it brings cosmetic and functional issues. What we call as been discussing are unspoken problems in women on face, skin, breast, fat, genitals, hairs, in men too. Now, this aging has been described in our Rati Rahasya in the 16th century for sexual aging, and there were potions and all given to these women and men who used to take for not aging happen. They were more interested in the sexual aging, so that's why all this thing came from the Egypt and from our own Rati Rahasya. Sexual aging is as important as the normal aging, because it can cause a lot of problem because of decreased libido, sustained erections, premature ejaculation, priapism in men. And you need to tackle this by changing the lifestyle, giving them antioxidants, some medicines, some devices, and some PRP stem cell shots in the penis, or even a penile implant. Similarly, we've been hearing about female sexual dysfunction, dyspareunia and all, stress urinary incontinence, vaginal laxity and all that. And again, all these treatments have been described in the Egypt, and you see these paintings in the pyramids on their paintings. And of course, by our own ancient treatise, the Indian female sexuality in the Rati Rahasya. So what I want to say is aging is natural. All of us should age gracefully with dignity. There are some anti-aging treatments which work. There are some anti-aging treatments which don't work. The choice is yours. But please do not try roadside or advertisement-based treatments, which claim to make you young. You have to consult a regenerative medicine specialist if you want to do. What you need to do is for anti-aging, proper diet, exercise, yoga, meditation, relaxation, no anger, eat right, sleep tight, be bright. And you need to correct your microbiome. So correct type of food, the fermented food, probiotic fibers, less of any white things, sweet, salt, maida, all out of your diet. Reduce your stress, avoid unnecessary antibiotics, regular exercise, and get enough sleep. Intermittent fasting also helps to increase the length of the telomeres. So 16, early dinner, late breakfast is what we call as the intermittent fasting, which helps. Avoid red meat. 5 ways exercise to increase telomere. Eat a telomere protective diet, which I've showed you. Manage chronic stress. Manage exercise. And incorporate supplements in your diet. What are the supplements? Thousands of herbal supplements are available, which claim to do everything best for you. But please select the right one and with the right advice. Thousands of anti-aging creams and cosmetics available. Please don't buy out of the counter cheap beauty products. They are more harmful than the real stem cell products, because stem cell products are expensive and has to be bought from a good tray people. There are lots and lots of antioxidants now available, and a combination gold, YQs, things like that, gold-based things and medicines. How much antioxidant, how much treatment you have to take, you just have to understand what deficiency you are and then take. Well, supplements have to be added. Metformin is said to be the anti-aging drug we have. It's safe, can be taken in the dose of 2 grams, sustained release per day at bedtime. For non-diabetic also, normal hypoglycemics. It will not bring down your sugar. It is an anti-inflammatory. So it helps in the inflammation. It helps in telomere lengthening it. This again has to be taken under the advice of a physician. There are some genetic testing which will test your cellular detoxification and will customize the anti-aging treatments. And these are available. And these taken in a 90-day therapy and repeated once a year. This is expensive treatment and has to do a test on you, because it is not brought over the counter. It is made, custom made only for you after checking your methylation cycle, what is the problem, because that is what is causing you aging. Then we have various hormone therapies. Growth hormone therapy is supposed to be the one which will cause you to be young forever. Estrogen replacement for women, androgen supplementation for women and men, progesterone in menopause, calcitonin, thyroid. The first hint that a body biological age can be reversed was by the use of growth hormone and to reverse your epigenetic clock. Now, what growth hormone does is IGF-1 in the body causes self-repair, and the growth hormone gives you more energy, better muscle tone, healthier immune system, and a youthful sex drive. It doesn't mean that all of us should start injecting ourselves with growth hormone, as it has been done in the Hollywood. All Hollywood stars who have these big muscles and everything, Sylvester Stallone type, all of them are taking growth hormones. And even some of our Indian stars are also on growth hormone. So growth hormone is a novel peptide. It helps where it is needed. Then we have this golden vial pre-prepared stem cell cocktail, which is available, which if you take it at the right time, under 40s, has said to decrease your biological age by 10 to 15 years. You can take it up to the 80 years. At 80 years, it will decrease your biological age by 5-6 years. So that, and make you young. Then there is another aspect of aging, which is the ovarian biological clock. Menopause, reproductive aging, premature ovarian insufficiency, and premature ovarian failures. So can we rejuvenate the ovaries? How old it is to have babies? Can we inject stem cells in the babies? What can be done? It is the mitochondria in the egg which needs to be rejuvenated. So there are some treatments of mitochondria. There's some ultra omega therapies, DHES, low dose testosterone, injecting PRPs, stem cells in the ovaries. All that is there, but a lot of it is still experimental and needs to be very selectively done with the right indication. So, ladies and gentlemen, anti-aging, what you are doing, what you should do is what you have to decide. Because aging can be fun and you can enjoy aging also. There are a lot of cosmetic surgeries which are being done for anti-aging. Surgical facelift, non-surgical laser face, injecting Botox in the wrinkles, removing all the wrinkles, looking very young skin and all that. On the sexual organs, labioplasty, penile implants. What we have to remember is it is not medically indicated. It is not yet proven to be very safe, all the treatments. Women are not educated about what is normal, so they come asking for everything which is there. Women are requesting these procedures without the need of psychological counseling. Doctors are promoting with unrealistic ideal, it will make you young as 20 years. Doctors are doing it for money, maybe. Yes. Is it unethical? Are women facing social pressures? There are seminars offering for industry secrets at a high price, which I'm telling you, the training sessions, which are going at 5-6 lakhs a training for 1 week or two, which tell you it can all be done very simply in programs like this in 3 days with the ICOG. We have not charged you a single penny. I've told you all the secrets of everything which is renewed. Remember, if you're going to offer these treatments of aesthetic, regenerative, cosmetic, anti-aging, the women in the village deserve the same as the urban women. And we cannot say this is only for the urban women living in Bombay, Bangalore, Delhi, or everyone is doing. The world is shy and it's not coming. The need of aesthetic gynecology, ladies and gentlemen, to conclude, is real. And India, it is coming more and more, as you saw with the experience of so many speakers. So if the need is there, we need to there. We were the few first pioneers who did the first courses in India, and now they're being offered by whole mushrooming of that. And the mushrooming is so much, it's like IVF, that finally we will see some guidelines from the government. We should follow all the guidelines. We are coming out with our INSARG guidelines. Join our association, the INSARG, and join courses which are run by authentic people like Alex Barder and all, and the people. These are the first 25 who did the first course in India, and you can see and you recognize them, and they were your speakers today in this ICOG course. So the INSAG offers you the need of real aesthetic gynecology in developing countries, and we are affiliated with we are the only Indian official organization. There are 10-20 organizations which are there. Yes, everyone is free to make an organization, run a course of their private, but they need to follow some guidelines. Thank you very much. Age gracefully is my appeal to all of you, and join INSAG so that we can keep you updated. Join the ICOG, follow the ICOG courses. We'll come out with a course material book on what we have done these 3 days and what we did last year also with Dr. Uday Thanewala. These 2 courses have been very, very successful. We charged in the course which we did last year, but here this is free to you, and it will come free to you once a year. Thank you very much for inviting me here.
Thank you so much, Narendra sir. Your lecture is always an eye-opening, and definitely this topic is really a different and new. And thank you so much for bringing this very important topic. Thank you, sir. So after this really a wonderful topic by our own Dr. Narendra Malhotra sir, it's the time to come to the next session. That is a wonderful panel discussion. But due to some reason, Dr. Ragini ma'am is not available for the panel discussion. So the moderation will be by Tanuja ma'am. So just I'm going to introduce
Lots of people are putting how to become members of the association. Yes, you can write to me, Preeti, we showed you the numbers, or Dr. Ragni, or to ICOG. ICOG, so you can become your Foxy member, you ICOG member there.
Thank you. So the panel discussion, the moderator will Dr. Tanuja Uchil ma'am. Ma'am is the diploma in reproductive medicine and the founder director of the OMA hospital at Mumbai, India, principal consultant of OMA hospital. Ma'am is the treasurer of INSAR, that is Indian Society of Aesthetic Gynae. Ma'am is a member of Mumbai Obstetrics Society. Ma'am is also member of European Society of Aesthetic Gynae, presented a lot of national and international papers. So over to you, ma'am.
Dr.
for
Apurva,
introduction
can I
of,
just,
yeah.
Dr. Apurva, this is Dr. Sarita Bhalerao. Can I
Okay,
just
yes, ma'am.
thank
Yeah.
everybody on behalf of ICOG? So it's wonderful to see Dr. Narendra Malhotra. And I know Dr. Ragini Agarwal is today giving an oration, so she's not here. But I really take this opportunity to thank Dr. Malhotra and Dr. Ragini Agarwal for this fantastic course. And really, it's been an eye-opener. I've been listening, and there are so many different new things that we really can't imagine. Thank you, Dr. Datta, one of the conveners, and a big thank you to all the faculty, chairpersons, moderators, and also to all the delegates. Thank you so much.
Thank you so much, Sarita ma'am. So Sarita ma'am is the Secretary General of Foxy ICOG, and it's her guidance that you are organizing this wonderful and beautiful ICOG certified course of aesthetic gynae. So thank you, Sarita ma'am, for bringing out this wonderful and unique program. Thank you. Tanuja ma'am, can you just please introduce all the panelists?
Yes. Thank you, Dr. Apurva, for your wonderful introduction. And I need to say.
Yeah, CVs is already there. Yeah, ma'am. I'm already sharing the CVs of panelists.
Okay, I wanted to share my.
I think you can remove the CVs. She'll just let us share it and let her just tell the names. No need for detailed CVs, please.
Yes. Shall I share my screen?
Yeah, sure, ma'am.
I'm trying to do that.
I think you need to make her co-host.
She's also already co-host, ma'am. Tanuja ma'am, you can go ahead.
Okay.
Yeah, it's visible, ma'am. Yeah.
Yes. So let us start the discussion. Aesthetic, functional, and regenerative gynecology, enhancing a woman's health and well-being. Let me introduce to you all the panelists, starting with Dr. Narendra Malhotra. He requires no introduction, but I will still put up his profile here. Hello, sir. Dr. Preeti again requires no introduction. She has so many accolades to her with her writing books and the workshops and so on and so forth. Dr. Milind Shah requires all stalwarts in their own way. You can read through whatever they have been doing. Dr. Prerna Keshan, our young and budding aesthetic regenerative gynecologist who's practicing in Assam. He's taken this to all the little places of India. Dr. Rita Bakshi too, who is using the energy-based devices and working in Delhi. Dr. Sejal again requires she was one of the pioneers to start aesthetic and regenerative gynecology in Mumbai. And Dr. Natasha is a dermatologist. She's very well into facial aesthetics and hair aesthetics too. So, do I have all the panelists?
No, ma'am. I couldn't find Milind Shah, sir, and Dr. Natasha also.
Dr. Preeti?
And Preeti ma'am is not there. Yeah, Preeti ma'am is also not there. So we have Narendra Malhotra, sir, Dr. Prerna, Sejal ma'am, and one other.
That's it?
Yeah, and Rita Bakshi ma'am.
Dr. Rita Bakshi is here.
Yeah.
Okay. Dr. Preeti isn't here, is it?
No, ma'am. Preeti ma'am, I think she was traveling at present. Probably she will join in a while.
All right. So let's start with discussing what do you understand by aesthetic, functional, and regenerative gynecology. So you can either divide it as definition of aesthetic, definition of functional, or definition of regenerative, or just pull it together and give me an answer. I'll address this to Dr. Prerna. Can you please tell us the definition of aesthetic, functional, and regenerative gynecology?
Thank you, ma'am, for the question. And it's indeed a real pleasure to be a part of this wonderful scientific session today. And all regards to Ragini ma'am and Naren Malhotra sir for taking out this particular wonderful, we executed the entire program so meticulously planned. So with this panel, we'll be moving ahead with a very new term, aesthetic, functional, and regenerative gynecology, which was termed by our stalwarts, Dr. Naren Malhotra sir and Dr. Ragini Agarwal ma'am. They had said that cosmetic gynecology was a misnomer for all years together, because when you use the word cosmesis, it comes to like you are wanting to have designer vaginas and all. So in the setup of India, Indian scenario, we being a third world country as the entire globe tells us so. Now since we are advancing, we want to show the world what we are actually doing in the field of reproductive medicine. So aesthetic and functional and regenerative gynecology starts from the improvement of the external appearance of the genitalia of the female, which increases her self-confidence and also her quality of life, because that includes procedures like labioplasty, vaginoplasty, even hymenoplasties, because that we have discussed in detail in the very first and second day, how labioplasty can really affect a woman's confidence and also her fertility issues. If labia is obstructing her vaginal canal, she can also have infertility. So these are procedures come in aesthetic part. That is about the appearance of the external genitalia, but it can be an elective procedure, but also can be opted for functional issues as well. We come to the second category, that is a functional gynecology. It is the most important part where we all gynecologists creep in for the improvement of the quality of life of the female in every nook and corner of our country. These females, they do not usually come to us with their problems. They silently suffer. Malhotras are always leaking, but they don't answer. They keep on having dyspareunia, but they do not have an answer to it. So these are the females where we need to dig in. They come out with lax vaginas, they come out with atrophic vaginas, but then they don't speak about it. So we want to dig into these particular females' problem and sort them out. In functional gynecology, it is about improvement of the overall health of the female. It is like an holistic approach. It considers physical, emotional, as well as reproductive well-being of the females who are silent sufferers. So this is where the gynecologists have the most important role to play. If we come to the last but not the least, the regenerative gynecology part. This is a very, very new field where sir has already spoken about stem cell therapies and so much of anti-aging procedures. Regenerative gynecology tells us something about restoration and regeneration of the female genital tract and the reproductive system, where damaged tissues as well as those aging tissues are taken care of. Either atrophic vagina or maybe a stress urinary incontinence, everything can be taken care of with platelet-rich plasmas, growth factors, and all these newly invented regenerative gynecological procedures. So this is how we are doing a holistic work in the field of AFR gynecology, and I hope this reaches to every nook and corner of our country. Thank you, ma'am.
Thank you, Prerna, for that great introduction. And the definition is right here, as Dr. Prerna rightly said. Aesthetic involves more to the appearance. Functional is about the functionality. So all those women who suffer from stress urinary incontinence, genital urinary symptoms of menopause, and all the other issues that come with it, like recurrent UTIs, atrophy, vaginitis, lichen. They are all the functional issues that can be taken care of and that we look into. And then, of course, the regenerative part, because we know nothing works as a singular module. You have to have a teamwork effort with your energy-based devices, with your surgery, with your platelet-rich plasma, with your stem cells and your growth factors. So I'd like to ask Dr. Sejal the common aesthetic gynecological procedures that we generally do.
Hi, everyone. Very happy to be on this panel. So thank you, sir and ma'am, for having me here. A lovely program. I think when we are primarily talking about procedures, if I were to go in just term of the commonest procedure we do, I think it's going to be energy-based devices and functional gynecology, because the commonest, symptom of urinary incontinence and GSM is what we are dealing with. I think the second commonest thing is going to be the electromagnetic stimulation chairs, again pertaining to pelvic floor dysfunction. The third will probably be labiaplasty, and I think labia minoroplasty and vaginal tightening are next on the go. Fillers are becoming more and more popular. So vulval fillers, botulinum toxin for vaginismus. So sorry, I think my voice is going. In order, I think these are the commonest things we do. And to almost everything, we are adding PRP today. So I think a combination of procedures is what's in store, but all of them are becoming very common today.
Yes, Dr. Sejal, that's really true. I'm sure you're doing it day in and day out, so you would definitely know what are the most commonest things that patients come to us to ask for. Dr. Rita Bakshi, would you like to add something to this?
Thank you, first of all, Dr. Ragini, Dr. Apurva, Dr. Narendra Malhotra, for adding me into this branch. In fact, to tell you, I trained under Dr. Preeti, and she has a wonderful course going on. And I'm glad ICOG started this, because all of us as gynecologists, IVF specialists, are all getting interested into this branch. Now, as far as aesthetic and regenerative procedures are concerned, they have already outlined these are the procedures which we do. Hymenoplasty, I think, has been coming to gynecologists for a very, very long time. So it is not something that is new, maybe done with finer sutures now, looking more at the aesthetic rather than only the functional part of making it as a barrier. Sex has suddenly, taken upper hand, and finding out spots which matter. So both the G-spot as well as the clitoral stimulation has taken. I think what's very, very important, Dr. Tanuja, also, I've seen some of the cases going bad. So, some of the time when the hood has been removed and the area becomes so hypersensitive that even rubbing of cloths makes it, so a safety concern there, I think, should be taken, with a, it should be under very trained hands. That's what I would say.
Definitely. You require a proper training before you start these procedures. Narendra sir, will you please shed some more light? Or would you like to add something?
So as we've been talking about in the last 3 days, or 2 days and 3 days, is that we have what we call as her unspoken problems. And women are really suffering. Women do not need to suffer. It is a era of women empowerment. If they want, they should get it. But we have to remember that there has to be a most non-invasive way of giving it to them. And we also have to remember that, see, most of you must have seen the Great Vaginal Wall. Now, this guy, what he did was that he took plaster of Paris, and 100 normal women impression of the vulva external genitalia was taken, and then a wall was made. Now, these are 100 normal, and all of them were different, but they were normal because those women did not complain. So whenever a woman comes to me saying that she wants a change in her looks or something, we show her the wall. See, if you're one of these, you're normal. But still, if you want, maybe we can do some alteration in skin lightening, maybe some tightening, maybe a mons pubis reduction, or maybe a non-mons pubis filling, or a labial filling, or you have extra labial internal lips which need to be done a labioplasty because you want to wear see-through clothes, you want to wear very tight clothes, which like the models do on the walking the ramp, and so it should not show. Yes, so if they want that, it has to be done. But again, remember, if we cut a normal vulva or a vagina, it comes under a very thin line of genital mutilation. So WHO needs to change that definition of genital mutilation with the cosmetic vaginoplasties coming in. And so be careful. If there is an indication, go ahead and do it. Try to do it as non-invasively, but that doesn't mean that you have to be a very good surgeon also, because some things will require surgical correction. And then the most of it, as Sejal said, will be by energy-based devices, but we should be as good in vaginal vulval surgery as we can.
So if I can just add something, Dr. Tanuja,
Yes,
some Indian statistics to it. We published this paper in the Indian Journal of OBGYN in 2016, which spoke about Indians accepting aesthetic genital surgery from 2012 to 16. In 2012, we had 4% people asking for it. In 2015, we had 30% of the people asking for it. A recent paper showing in an aesthetic gynae clinic, 77% of the women who walk into India are for urinary incontinence. And we've managed to publish these very large papers just because now of the awareness growing in aesthetic gynecology pertaining to SUI, and recent paper with Tata Hospital about cancer survivors. Now
Right.
they want to have a better, quality of life. And that's a very interesting paper we published this year. So yes, it's been growing and growing and growing.
Because very very rightly said, Sejal, because what has happened is like sir said and you said and even Rita ma'am said, what patients come to you is for functional issues. Most of them come to you for functional issues. SUI and the genital urinary symptoms are one of the major things that they come to you for, and they're asking you for a solution which I think some years back, at least 10-15 years back, we could not give them, and we can definitely give them now. So it is so it is so gratifying that you can treat them. Onco is one place, definitely, because of the chemotherapy and the patients going into early menopause. The energy-based devices really does wonders for them, and they can regain their life back. This is so true. That's why it's really great to do all these things under the huge banner of aesthetic and functional gynecology. I see Dr. Preeti has joined us. Dr. Preeti, would you like to speak about the indications? Preeti, are you with us? Okay, I go to the next because we have covered all this. As I said again, energy-based devices form major part of whatever we do. So I'll start with Sir. Sir, which is your favorite device? And controversial topic, but I'll still ask you.
So all these energy-based devices work by the same principle. They're causing aseptic thermal injury to an area where we want the collagen to remodel. So we are working and not at the surface, we're working 4 to 6 or mm below the surface. We want to target and not going more deep so that we don't damage the blood vessels down there. So you can have the RF, which will cause surface heating and the temperature. Sometimes the patient will burn. This is radio frequency. You can have the non-ablative lasers, which do not ablate and heat that area. You can have micro-ablative lasers like the CO2 fractionate lasers, which causes very, very micro holes in 1 square centimeter and heat that area below. You can have micro needling RF, micro needles in RF. You have the diode laser, which is only heat laser. So we started our work with CO2 fractionated lasers, and we were doing everything with it. And we have now added the diode laser just for being a total non, because some people said that's invasive. So that's I have experience with CO2 the fractionated laser, the FemiLift, and the Sabrina, the diode laser, and of course the other facilities. And you can do a lot of work. You can do cutting with them. You can do incisions with them. There are people who I know they claim we are doing laser cesareans. Now, laser cesarean is cutting the skin with that CO2 laser, ablative laser, which could be any. And remember, one laser cannot do anything because they work on wavelengths and they attack a different color, chromophobe. So they attack water, that will cause cell death. If they attack hemoglobin, you're going to work on that. If they attack melanin, according to different wavelengths, and one of them will not have, one laser will not have all wavelengths. CO2 has 10,600, diode has 1470, and so it's divided. So for tattoo removal, for skin whitening, for melanin removal, is different. Then you have the IPL, the photo laser for hair removal. All those are temporary because they attack the black pigment. So they attack pregnancy. So we have to understand which energy-based device you require, where you require, what actually you're going to do. And it is better that you have a dermatologist partner or a dermatologist husband or a dermatologist wife with you, then your laser will pay back very fast.
Yes. That's a difficult option right now.
So for those youngsters who are not yet married.
And Rita ma'am, will you like to say which one you prefer? Which energy?
So you know, as Dr. Malhotra said, I think we all Dr. Malhotra started much earlier. So, you know, CO2 lasers were at that time. So, and you get experience from the type of machine that you have. I started with diode laser, which is a semiconductor, and it's one of those very safe laser. I think safety was something as a gynecologist, you know, because I didn't have a derma partner with me. So I was really bothered on the ablative part of it. So I said, okay, a non-ablative laser, which is much safer, very easy to do, very short time. So, you know, I started with diode laser, and that's the laser that I am comfortable with. It's given me good results. And you know, and because the time also, you know, it just requires 3 sittings and with only 2 weekly intervals in between. So I thought the time was short. And in the beginning, I did, you know, with vaginal laxity, that was the patients who will be coming to you the easiest. And I remember my first patient extremely happy. So, you know, at that time, I really thought, because she came back and she said, I never had it this good. So that really put my faith into the diode laser. So I think to me, the safety part was very, very important. And that's why I did not dare with the CO2 laser, which I know is very, very effective, but everybody to their own.
Sejal, I know you use radio frequency, but just 30 seconds on it.
Okay, love monopolar radio frequency, and in both my clinics, that's what I primarily use. But began with the FemiLift, actually the CO2 laser in 2013. We did this first Indian studies. Currently, we have RF, a CO2 laser, and a diode laser in the clinic. So, like everyone is saying, not one thing does everything. You need something separate for cutting. You need something separate for menopausal women. But yeah, my one single go-to tool probably would be RF.
Yes. And I guess the hybrid lasers are just around the corner, so they should make our life more easier.
Yes.
Prerna, would you like to put in some input?
Ma'am, with Dr. Rita Bakshi, ma'am, I prefer
Okay,
safety
okay,
and not much in my armamentarium. I have the diode lasers. With
okay, great. That does great work. So, Preeti, are you there? Are you not there? I did see you, so I'm still searching for you. She's not here. Okay, so these are some of the procedures. These are some of the surgical procedures. These are some of the non-surgical procedures with the energy-based devices. Scar and stretch marks, episiotomy scars, lichen sclerosis, vulvodynia, dyspareunia, HPV, molluscums. These are what can be really well taken care of with the energy-based devices. And these are some of the surgical procedures. Sejal, would you like to speak on some of the surgical procedures that we are doing?
Sure. So the commonest surgical procedure probably we are doing is a labia minoroplasty with a clitoral hood reduction. Just going into types of labia minoroplasty, though books describe many things, the two things we actually do in practice are a curvilinear excision or a wedge. I feel curvilinear excision is a little safer because we don't cut off blood supply. The results are fairly good with that. Only issue with that is you have to learn a clitoral hood reduction, lateral or central. So the clitoral hood doesn't look very prominent, but overall satisfaction, all papers state of labiaplasty are really high. Just a precautionary sentence. A lot of women walk into our clinic saying, I want a labiaplasty or a hymen for vaginal tightening. We have to spend counseling. They don't know what they're saying. And we know that labiaplasty has nothing to do with any kind of vaginal tightening. I think the second commonest thing we do is a vaginal tightening. Remember, it's not just an introital tightening. So a lot of gynacs feel that we've been doing P repairs forever. Sure, you've been doing a great job with P repairs. The only thing about this is we go much deeper. We can do a nearly 7-8 centimeters depth of vaginal tightening, go wide up to the ischial spines, and build a great perineal body, which is very good for the posterior vagina. The next surgical thing commonly done is a hymen reconstruction. I think most of us are good with that. It's only challenging when there's no hymenal remnant, and then the flap techniques need to be learned. The other thing we are fairly doing commonly now is a liposuction combined with fat filling. So a lot of post-bariatric patients who have weight loss, who have hypovolume of the labia majora, are now looking forward for filling up the labia majora to look youthful, and adipose tissue grafts is what we are doing there. The surgical procedures are, one time. Patients are very, very happy with them. And I think most of us are having very good success rates with that. We've just studied the surgical procedures a little more using the FSFI index, which is the instrument we use for vaginoplasties. And only 3.9% of our patients were not satisfied, the rest being super satisfied or satisfied. So I think it's been pretty satisfying, the surgical bit.
Yes. Sir, would you like to say a few words?
I'd like to add on here. Yeah, ma'am, I would like to add on here with Dr. Sejal.
Yes,
Yeah,
yes.
please add.
Yeah. As sir had said, the great wall of the vagina, that the mounds that have been prepared with the different normal females. So the very important thing that every beginner should note, what sir had said, that this particular people, this particular set of females, they are otherwise healthy individuals. They are otherwise healthy individuals who have this labia sagging or labia and lengthening, or a loose one that is hanging out there, enlargement post the labia minora, labia majora. So these are the women who need to understand that since they are otherwise healthy, they have come to us for a functional change, or maybe a quality of life change, or maybe they want to feel better about themselves or feel more confident about themselves. So a better counseling and a thorough documentation of the initial anatomy and the entire procedure should be explained in detail prior to jumping on to any procedure in an otherwise normal, healthy individual.
Yes. So sir, you were saying something?
No, I was saying that you have to be a good vaginal vulval surgeon before you take this branch of cosmetic gynecology. So that you can't say that I would do only non-invasive. For anyone who comes, I'll do an RF or a CO2 or a YAG laser. That's not the answer. You have to classify. See, now for this first which you are seeing, your first picture, you can do nothing with the energy-based device. This has to be corrected surgically, and followed by for these labia lips hanging, very big labia lips, labioplasty, surgical labioplasty is required for these two. If they are models working with tight hugging clothes and see-through clothes or bikinis, so this cannot be done. So we have to be good surgeons before.
Yes. So to summarize,
Dr. Tanuja, sorry, just one sentence. As a gynecologist, unfortunately, we examine patients from the cervix, sometimes from the vagina, but never from the vulva. I think our knowledge of clitoral hood and labia is really poor. And that's why the training, we really need to look at it and train ourselves for it.
And how many of the gynecologists look at severe PCO girls, look down at the clitoris? None of. Even I used to never look. Now I've started, because see, it's hyperandrogenic, and that might be showing there. That might be a sign. Just have a look there, and if she has a severe clitoral problem, then maybe she'll require surgery later on, or whatever. And you have to rule out the androgen problem or the adrenal hyperplasia problem. So we need to look at even for unmarried girls who are with irregular hyper and obese and hirsute and acne, the clitoris might be a problem. And there was a huge protest in Brussels, and saying that recognize clitoris as a different organ by women. And so that we need to, very right, we need to look at all those things. Definitely, yes.
So to summarize, we definitely need to have a look. As I said, there are so many things that earlier we would be sending it either to the dermat to take care of, or we would just not know what to do. we have to address all these issues. We have to know our subject thoroughly. The labia majora, minora, the mons is all our area. We cannot just ignore that. So if a patient who walks in and says that I have an asymmetrical labia, please do something about it. You just cannot tell her, no, go away, this is fine. You cannot lecture her or be judgmental about it. You have to take care of it. Fillers are coming in a big way. Threads are coming in a big way to take care of the labia, to take care of vaginal tightening and also for the lifting of the labia majora. So those are few
And
things.
another thing, one more point. Most of the government hospitals or even the episiotomy repair is done by the junior most and sometimes the nurses. I mean, the episiotomy repair has to be done by the most experienced gynecologists. That is why you see so much blotched up episiotomies, so much gaping scars. And then, see, yesterday I did a TLH for adenomyosis and the husband came, you see, please do a repair also because you just see if sexual functions improve. So
Yes.
episiotomy repair also has to be done very, very meticulously.
Yes. There are a lot of patients in their 40s who ask us this even when they are going through a TLH, that please do something. I don't want to lose on my sexual function. I don't want the pigmentation that comes with going through perimenopause and menopause. Please also help me to take care of that. So moving on, we already spoke about how energy-based devices work. And let us speak about safety and efficacy of these devices. I'm sure they're all very safe. We know that they're all very safe because we have been working on them. But just for the audience, let us just speak about safety with all that we are doing. So first, do no harm is always our motto. Sir,
so if
please.
it is a non-ablative device, then you've got to not worry at all.
True.
Because none of the studies till date have shown any burn or anything. If it is an ablative device, you're going to use it for cutting. So you are cutting, so you are causing a cut. So you have to repair that cut. If it is a microablative device or a semi-ablative or a fractionated laser, right now till date, also no scarring or nothing has been reported. But potentially all ablative devices can cause scarring and fibrosis. But I don't think that's why the studies have been submitted to FDA and FDA is approving all of them for use in vagina now.
True.
So I think, you know, he's very right by saying that ablative devices are the ones, and it's very, very important to know your machine also very well. You know, I'm sure the scarring and the problems that occurred, which seem to have occurred whenever, it maybe because, you have to know the time for which you to expose. So
and the
I'm sure, you burn I mean, and this is only in ablative. So you only cause that when you really don't know your machine very well. So
And
it's
Dr.
very,
Rita
very
Bakshi, we're buying the right machine. See,
Yes.
the market is flooded with cheap Chinese machines.
True. Very
No,
true.
not standardized at all.
Absolutely.
If they're saying 10 joules, it might be giving 50 joules, it might be giving so much wattage, it's not standardized at all. Please don't go for and buy all those smaller joules.
Absolutely.
I
So I
think
think
we
we
should
talk
go for
to
the post-test. I think if we are finished, we should go for the post-test.
Yes.
People are getting restless, I believe.
One ethical considerations I'm not speaking about because I think most of us practice ethically and morally. I will just go to the future directions. Anything new that is coming up that Sir, Rita ma'am or Sejal ma'am would like to speak about?
Let me just say a word about ethics. When you go to USA and you read a woman's magazine, there are full pages. Come get your vagina tightened in 10 minutes for $400. I mean, I don't know whether those advertisements are ethical or not.
Sir, India में नहीं होता पर.
इंडिया में आएगा ना, अभी आ रहा है ना, फ्लड हो रहा है. You look at this Time magazine behind me. It is carrying a big advertisement inside.
Yes. Newer children on the block, newer kids on the block.
Well, newer kids on the block, I think a few things. One is the CO2 laser has traditionally always been microablative. It's a fractional laser. But the first CO2 laser non-ablative is made in India, and we are using it at our center. That's new. I think in the zone of PRP, what is new is PRF, or that's PR fibrin. Exosomes are available. You are getting powdered lyophilized PRP over the shelf. We don't need to to collect it from the patient. I think that's very, very exciting. Dr. Tanuja, you already mentioned, combination lasers and hybrid lasers. So, combinations between different like monopolar, bipolar, multipolar on the same platform is available, or combinations of different lasers like erbium YAG with CO2, RF with something, ultrasound and RF together. So yes, I think it's just booming. I think every day there is something new in the market, and it's very exciting because there's so much competition now, and because they're all trying to outdo one another, I think we are benefited and our patients are. So yes, I think it's really going high, and we are the fastest growing segment, Southeast Asia in aesthetic gynecology. So definitely.
Definitely. Prerna, would you like to say something? Rita, ma'am?
I think Sejal's covered literally everything which is new in the market.
Narendra,
Someone is saying on the shelf. Someone is saying on the shelf PRP will have reactions. No, plasma will not have reactions. It's lyophilized and
on the shelf, microneedling also.
A lot of future direction.
Can sir please summarize for us?
So we have had a great bonanza of academics in a new field for the last 3 days. And I see the pre-test and post-test have been very, very good. And with the messages which I'm reading, everyone seems to have enjoyed this. There was some concern on the day one about the terminology we are using. Someone did send me a message saying that you are, the ICOG should not hold courses like this till they are there. Well, if we don't hold courses like this, then we will not be able to tell what is right and wrong. And of course, the government of India is going to bring regulate it. The NMC will allow all this. There are machines which you say are cosmetic machines and medical grade machines. Whenever you're buying a machine, buy a medical grade machine. You pay lesser GST on that, and you're more of it. So what my advice is: read, see and learn, and don't hesitate to ask. You ask, we will answer, and that is what knowledge is. No, knowledge cannot be locked behind doors. The doors of knowledge cannot be locked. If I don't give you, someone else will give you.
Yes.
That is what we've been doing on training and this thing. So do keep in touch with ICOG. Do keep in touch with personally with all of us. Whatever you want, we are all there. And for the youngsters who are still deciding, don't want to deliver babies, don't want to have night duties, are not married, marry a dermatologist if possible, and open up a cosmetic clinic, 10 to 5 job, pays you well, gives you great satisfaction to make women look nice and women look healthy and give satisfaction to their life. So this is because ART is also now difficult. For laparoscopy, you need to be trained a hell of a lot. ART, the law has come, so you cannot open up. Cosmetic gynecology is a good new branch to choose only for that. Thank you for attending this course. Thank you to all the speakers for making it so. Out of all the presentations, we will be making a manual which should be ready within a month or two. And I'm sure the ICOG will put it up on the website for all of you to download. And the hard copies, of course, will be available at a nominal cost, which we'll let you know as soon as it is ready. Thank you.
Thank you.
Thank you
so
Thank
much
you
once
all
again.
panelists for being here and for answering all the questions so nicely. And as to summarize it, know your subject, know your physics, know which machine you are buying, and of course get properly trained. That's really very important. That's really very important. As sir said, sir and ma'am are always there. All of us are there to help you all out. Please, we welcome you all for any questions. Thank you.
I just have one thing to say to Sir. Sir, I'm much older, but I'm going to take your advice. It's not only for the youngsters.
Thank you.
Which
Thank
one?
you
Which
so
advice?
much.
Thank you.
Thanks, everyone.
Thank you so much, moderator Tanuja ma'am, and our wonderful panelists, Narendra Malhotra sir, Sejal ma'am, Prerna, and Rita Bakshi ma'am, for making this discussion and this panel a really successful one. So I think if you have all the delegates, if you have any queries, any questions, yes, please put in the chat box. Our panelist and moderator will happy to answer you personally. And secondly, I think it's a time for the post test.
Yes, sir.
Can you please share the post test?
They've,
Neeraj sir?
Apurva, they've already shared it. They've already shared
Yeah.
it. Yeah.
Yeah. Please put timer. Yeah. All the delegates, please check in your chat box. The post test is already being shared and your time already have started. Thank you. last 2 minutes.
All right, the time is up for the post-test. May I now request Dr. Apurva Kumar Datta, our coordinator, to share the answers for all the for the third day post-test?
Yes, sir.
Apurva?
Thank
Yeah.
you. Thank you, sir. Yes, sir. Thank you so much, sir. Gauriji, so this is the third and the last day of ICOG Foxy training certified online certified course on aesthetic gynae, and the answers I am sharing it. Yesterday also there was some confusion and some controversies, and definitely we will revert back to you with the answers, because there are 2 to 3 answers which are controversial. We will share it very soon. So the first is stress incontinence increases with age. It's absolutely yes, it's true. It increases with the age due to laxity. Which type of incontinence is caused by weak pelvic muscles? And definitely stress. Incontinence never gets better without treatment. It's false. Yes, the treatment is available. The losing weight can help in reducing the SUI. The answer is true. Spicy food can cause urinary incontinence. Yes, it's true. Which of the following is not a method used for non-surgical vaginal tightening? And yes, the answer is the Botox technique. Yeah, it's a need the prick and Botox. The pre-filled injections are available. We all know. Which non-surgical technique uses heat energy to stimulate collagen production in the vaginal tissue? It is the radio frequency. The option A is the answer. What is the primary goal of non-surgical vaginal tightening procedure? The answer is to improve the sexual satisfaction. Yes. Which of the following is a potential benefit of non-surgical vaginal tightening? The answer is the C. It's improved the vaginal muscle tone. Question 10. Which factors should be considered before undergoing a non-surgical vaginal tightening procedure? The option is option A, current hormonal medication. What are the causes of vaginal laxity? Pregnancy, childbirth, aging, and pelvic surgery, all of the above. What are the treatment options? For the vaginal laxity, it is energy-based devices, it is the PRP, surgery, and answer is all of the above. Posterior colporaphy alone can treat the vaginal laxity. It's false. We also have to do the anterior wall. What are the newer technique available for VLS? And the answer is all of the above: laser, RF, and HIFU. What are the indication of perineoplasty? Sexual, functional, psychological, aesthetic, all of the above. Answer E is the correct answer. What is the carboxytherapy? It is the diffusion of CO2 under the skin, that option D. How does carboxytherapy work? It is option C, by increasing the collagen production. Question 18, what is the primary purpose of carboxytherapy? For option A, that is the skin rejuvenation. Which gas is typically used in carboxytherapy? Carboxytherapy, definitely CO2 is the main gas, or it is the only gas can be used. Carboxytherapy is commonly used to treat which of the following skin condition? Under eye, cellulitis, stretch mark. D, option D, that is all of the above. Cell of our body renew skin 1 month. Option B is stomach 6 days, intestine 1 year. All of the above, none of the above. The answer is the option E, none of the above. Telomere shortening leads to all except, that is option C, cell renewal. Next, please. We can reverse aging by option C, epigenetic manipulation. Why some people ages faster? It is the genetic, epigenetic, environmental, lifestyle. The answer is option E, all of the above. The drug for anti-aging, metformin, antioxidant, growth hormone, golden vial. The answer is E, all of the above. Now, what is genitourinary syndrome? Definitely, it is typically used for the menopause. So, option A. What is the role of EBD in GSM? It is the regeneration of the genital urinary epithelium. So, it is the option A is the answer. Which is not a silent suffering? It is the option D, the post-menopausal bleeding. Other can be, you can use this in other option A, B, and C, and not in D. In which condition involuntary pelvic muscle contraction occurs? That is option C, Levator-Ani syndrome. Vesicovaginal atrophy lead to sexual dysfunction, and definitely it's true. Option A. These are the questions. So there is a lot of queries regarding the certified courses. You have to attend all the 3 days, and you at least have to give the post test and secure at least 50% of the mark. Then only the ICOG certified this certificate can be issued to you. So
Thank you,
Over to you,
Apurva.
Parag sir.
In the chat box, if you go through the messages, there are still some controversial question answers. So I would urge you to go through it, note them down and talk to the course conveners, Dr. Malhotra and Dr. Agarwal. And whatever are the right answers, I think we can make a document and then we will put it on the ICOG website so that the correct answers are passed on to all our delegates. So at the outset, let me thank all the faculty today, Dr. Seema Sharma, Dr. Poonam Mishra, Dr. Riddhi Shukla, Dr. Preeti Jindal, Dr. Narendra Malhotra, Dr. Tanuja Uchil, who moderated the panel, Dr. Prerna Kishan, and Dr. Rita Bakshi, and Dr. Sejal Ajmera. A big word of appreciation to our conveners, Dr. Ragini Agarwal and Dr. Narendra Malhotra. Of course, there have been some question marks or controversies, but as very rightly said by Dr. Malhotra, this is something which is coming up and it is a good learning for all of us. So it is always nice to learn newer things, update ourselves, and then apply them wherever you feel right in the right patient. I must thank both the coordinators, Dr. Apurva Kumar Datta, who's the Foxy chairperson of Sexual Medicine Committee. Apurva, very good job done. And Dr. Suman Sinha, who's not here today, but she is the Foxy chairperson of Vaginal Surgeries Committee. So on behalf of all the ICOG office bearers, the chairman, Dr. Parul, and all, thank you very much, all the faculty, conveners, coordinators, and delegates for attending this course. Those of you who've secured more than 50% marks in all the three post-tests will receive a certificate from ICOG office online in a month or so. So thank you very much, and we meet again next month for yet another interesting course. So stay tuned, and we are hoping to connect to all the Foxy members. So next time, probably through the Foxy and ICOG office, we should be able to reach out to all our Foxy members so that they get more and more information about these online courses, which you can participate in sitting at your home or at your clinic and get yourself educated. Thank you very much and good night.
Thank you so much, sir. And from all of us, we would like to thanks to the Foxy President, Dr. Jaideep, thanks to the Secretary General Foxy, Dr. Madhuri Patel ma'am, to the ICOG Chairperson, Parul Kotawala sir, ICOG Chairperson elect, our dear Dr. Parag Viniwale sir, the Secretary, Dr. Sarita Bhalerao ma'am, all the conveners, the vice chairperson, we have a Sheila Mane ma'am, the Narendra Malhotra sir, then Ragini Agarwal ma'am, for organizing this such a beautiful program for all of us, and really all the delegates. We have seen a really a good number who are attending there and making this certified course really a grand success. So thank you so much. Thank you.
Yeah, thank you. Bye bye.